Kumar, who is the professor and head of Department of Anesthesiology, Pain and Critical Care Medicine at St. G.S. Medical College and KEM Hospital, Mumbai, with a very vast experience on this topic. Madam, I am really happy and honored to welcome you on behalf of ISA Kerala State Chapter. We have a team of panelists who is sharing us their experiences and interacting with the team on this topic. Dr. Sunil T. Pandya, who is the Director, Anesthesia, Pain Medicine and Surgical Intensive Care and Obstetric Critical Care, Century Super Specialty Hospital, Hyderabad. Dr. Sunil, on behalf of ISA Kerala State Chapter, I welcome you to this meeting. We have Dr. Anju Grewal.
Thank you. Thank you, sir.
Thank you. Okay. We have Dr. Anju Grewal, who is the Professor, Department of Anesthesiology, Dayanand Medical College and Hospital, Ludhiana, also the part of this expert panelist. Madam, I welcome you to this meeting on behalf of ISA Kerala State Chapter.
Very good evening and thank you so much.
We have Dr. Kajal Jain, who is the Professor and Department of Anesthesia and Intensive Care from the prestigious Postgraduate Institute of Medical Education and Research, Chandigarh, with a very extensive experience on the clinical scenario of the subjects. Madam, I welcome you to this meeting.
Thank you very much. Thank you very much.
We have our own member, Dr. Anil Satyadas, who is the Associate Professor, Critical Care and Anesthesiology, Government Medical College, Teacher. We are expecting him soon. Dr. Anil Satyadas, I welcome you to this meeting. The second part of today's discussion is setting up a COVID ICU and OR. We have Dr. Sajesh G, who is our past president and senior consultant and head of Department of Anesthesiology, Nayar Medicity, Trivandrum, who was really at the beginning lot of experience in and was moved over to Bombay when the cases were increasing and has led the team which set up an ICU at Mumbai. Sir, Dr. Sajesh, I welcome you to this meeting. I welcome our President-elect ISA National, Dr. Venkatagiri KM, who is with us in organizing this in a much acceptable way. Also, I take this opportunity to welcome today's webinar coordinators, Dr. Rajesh MC, who is the scientific chairman of ISA Kerala State Chapter, and Dr. Vijish Venugopal, who is a professor, KMCT Medical College, Kozhikode, and governing council member of ISA Kerala State Chapter. One word I would like to say that we have got a lot of appreciation from many senior teachers and postgraduates that this is the one of the unique program in the country where they are all becoming part of it continuously and they are really benefiting it and requested us to continue. I also welcome our vibrant secretary, Dr. Bill Isaac Matthew, who is taking all the sincere efforts in organizing this in a wonderful way. And I take this opportunity to welcome all our senior teachers, all the delegates and officials to this meeting, and request Dr. Venkatagiri for his opening remarks. Over to Giri, please.
Good evening, President Nazar, Secretary Binil. Today's faculties, Indrani Madam, Anju Madam, Kajal Madam, Sunil Sir, and our coordinators, Vijish and Rajesh. It is really a wonderful day today because our practice, most of our practice is obstetric practice, and I think nobody is there who is not practicing obstetrics, maybe cardiac anesthetists or so. And we get a lot of cases where we can't postpone these cases, we have to take up. So there are a lot of doubts among many of us. If a COVID patient comes in emergency or COVID positive in emergency, because in different stages they may come. Patient, because even one HOD of medical college, she asked that if the patient is on a CPAP or this thing and for emergency, what to do, how to go ahead, whether it was spinal or GA, therefore theory works or what we have to do. So we thought that yes, we should have a talk, and hence thought that we will have Madam Indrani for this, and she will be the ideal person to give a talk. She happily agreed, and I am very thankful to her for this nice gesture. And after that, we thought that okay, that only because we should have a good discussion. Not only we, but there are many experts who are dealing with these cases every day. Sunil is doing critical care in Hyderabad, Dr. Anju in Ludhiana, and in Chandigarh, Kajal. So we thought that we will involve them and get the experience of them. So the time will not be constrained in the discussion. We will have a discussion because we need not restrict to 20 minutes or 30 minutes because we should have a come out and people should have clear the doubts and because we can't meet each and every person, go and ask physically anywhere. So I hope this will be a good discussion and all can pour their experience and discuss and we can do a better practice or see that what others practice and do. That's how we have going ahead. So Madam will be, Indrani will be giving her talk and leading the discussion and others, all the panelists, all experts in their field will give their experience and answer the question. Together we'll make it a good CME because it is so important that already the participant crossed 225 in Zoom. That means it is very much sought everybody. So there are very, very seniors like Dr. Kameshwar Rao, Dr. Chittora, Dr. Kirpakaran, and there are many, I have not seen others' names in between. All have joined. That means everybody is interested in this topic and want to hear. It's over to you to start this program, Rajesh.
Rajesh and VS, you can take over and start the academies. Dr. Rajesh?
Dr. Rajesh, please unmute and talk.
Yeah. Thank you. Thank you. As Dr. Nazar said, introduced, this is a very contemporary topic, and anesthetists are always confused with two things: how to give anesthesia, safely give anesthesia for these patients, and how to protect themselves and their colleagues. So we are very fortunate to have senior faculties for the same. And Professor Indrani Hemant Kumar will be, she is a professor and HOD Sage GS Medical College and KM Hospital. She will be dealing with the first session, anesthesia for pregnant COVID patients. And along with her, there is a panel of experts across India, Dr. Sunil Pandey, Dr. Anju Grewal, Dr. Kajal Jain, and Dr. Anil Satyadas. They were all introduced by our state president itself. So without wasting any time, we'll go to Professor Indrani Hemant Kumar. Over to you, madam.
Good evening, respected Dr. Nazar, President ISA Kerala Chapter, Secretary Dr. Binil, my friend Dr. Venkatagiri, who is President-elect of National ISA, Dr. Rajesh, and my dear friends. Thank you very much for inviting me for this prestigious platform. And as everyone said, all of us are every day facing patients, COVID patients presenting for cesarean section. And in fact, anesthetists are among those healthcare workers who are at high risk and becoming infected because of their close contact with infected patients, and they have a high potential of exposure to respiratory droplets or aerosols from these COVID patients. Workload in the delivery room is not going to decrease, and planned cesarean sections cannot be postponed during this pandemic. So this lecture will in effect deal with how we could give safe anesthesia to a pregnant COVID patient, safety from the patient point of view, as well as the anesthetist point of view. I hope all of you all can see my screen.
Yes, madam, you can see.
Okay. Not able to change the slide. All right. So to start with COVID-19 characteristics, we all know the causative agent is SARS-CoV-2 virus, and the incubation period is ranging from 3 to 7 days. Common manifestations, the patients can come with fever, weakness, dry cough, nasal congestion, runny nose, sore throat, and diarrhea. Progresses rapidly to acute respiratory distress syndrome, septic shock, refractory metabolic acidosis, coagulopathy, and multi-organ failure. Based on the clinical presentations, laboratory tests, and imaging studies, the severity of the illness can be categorized as mild, moderate, severe, and critical. So if you look at this, this picture, you'll understand that it is COVID has a multi-system involvement. So all that we are concentrating is only on the respiratory pneumonia, but that is not all. It has got implications in almost every system in the patient. The coagulation, the cardiovascular, immunity, adrenal, cardiac, neuro, kidney. However, we also have to have some answers about whether it has any implication in the, whether it affects the placenta. What is its implication when it affects the placenta? Does it have any implication with breastfeeding? Is it transmissible through the breast milk? All these concerns are there in front of us. So to start with, I would have to say that all pregnant women are not at increased risk of severe infection than the general population. So the risk of severe infection, which is about 15%, or sorry, 5%, is as good as any other population. So, but the pregnant patient with comorbidities, like those of hypertension, diabetes, asthma, HIV, chronic heart disease, liver disease, lung COPD, kidney disease, those with solid organ transplants, malignancies, or with immune suppression medications, they are at very high risk for severe illness, and it is consistent with the general population who are also at high risk. But one thing which we have seen in our patients, there is a trending that it is more common in the diabetes and in the obese parturients. So these are the ones who need early admission and strict monitoring of the vitals. 85% of women have mild disease, 10% more severe disease, and 5% have critical disease. So the diagnosis, as well as the multi-system involvement and the severity, can all be assessed by doing the following tests. So what are they? A HRCT with an abdominal guard, and that will reveal the presence of unilateral or bilateral pneumonia, patchy consolidation, ground glass opacities, inflammation, and if there is any pleural effusion. Lymphopenia is marked in these patients. Thrombocytopenia is seen. So all these have implications in a pregnant patient. ABG in severe cases have to be done. So we need to know the PF ratios. Elevated C-reactive protein can be seen in some patients. Serum albumin may be low in these patients. D-dimer, if there is you can have D-dimers, IL-6, serum ferritin, liver enzymes, especially LDH elevated. Serum creatinine can be elevated in those patients with kidney involvement. TROP-I and TROP-T in the presence of myocarditis and cardiomyopathy. And if the patients have heart failure, the BNP or NT-proBNP will be raised. So the clinical management and treatment, as I said, we divide them into mild, moderate, and severe. Mild can have an home isolation if they are asymptomatic. They have to be, however, strictly monitored. A pulse oximeter has to be there. They have to record the temperature, respiratory rate, and at least the oximeter reading should be more than 95%. They are also on vitamin C, vitamin D, zinc, and if they are mildly symptomatic, azithromycin. If they're having cough and fever, then they also get azithromycin, which is safe during pregnancy. Stage 2, if the patient is having moderate disease, then these are the patients who need hospitalization earlier than later. So the pregnant women infected with COVID-19 should be managed in an expert teaching or in a multidisciplinary hospital. They need antibiotics, steroids, methylprednisolone is generally given for pneumonia, oxygen support, mask or binasal prongs, remdesivir is given, and in more severe patients, tocilizumab is given, and prone position in the presence of gravid uterus. So you see the feasibility and safety. I have put in a picture of a prone pregnant woman. See the feasibility and safety, and if it is feasible and safe, you can prone the patient. And these are the patients who need early induction before they can go into the severe stage, before they can deteriorate. In the severe stage, these are the patients who are admitted in the ICU. They are on steroids. As I said, methylprednisolone is continued, remdesivir, antibiotics, tocilizumab, oxygen support in the form of HFNO, BiPAP, or a ventilator, because these are the patients who have an increasing oxygen requirements, and which means that these are the patients with a disease progression. And mind you, if you feel that the oxygen requirements are increasing too much, then a decision on invasive ventilation has to be taken earlier than later in these patients. Dexamethasone for lung maturation and magnesium sulfate as a prophylactic for fetal neuroprotection has to be given. Early decision on delivery can definitely improve outcome. Induction of labor with oxytocin. And if these patients have a uterine contraction fatigue, or if the patient is having postpartum hemorrhage, we do give carbetocin or carboprost, but then kindly note that it can cause bronchospasm in these patients. And of course, many of them in the severe stage can turn up for an emergency cesarean section because of increasing hypoxemia and fetal acidosis, leading to an emergent cesarean section. So what are the pharmacological agents which are given, which can affect the COVID-19 patient during pregnancy? Let's start with hydroxychloroquine. Caution is exercised in women with underlying mental health problem, patients who are taking hydroxychloroquine, especially because it interacts with antipsychotics and antidepressants. More than that, it is known, the methadone is known to increase the QTc. So they are prone to have torsade de pointe and a potential death. So especially if it is combined with azithromycin, which is given as an antibiotic. So as it is, however, remember, azithromycin is safe in pregnancy. You need to have a proper ECG before starting these patients on azithromycin or hydroxychloroquine. And azithromycin is compatible with breastfeeding also. Remdesivir, if it is given outside the first trimester, you have to see the risk-benefit ratio, because it can cause liver failure, it can cause renal failure. So you need to know the risk-benefit of these patients while giving remdesivir. Favipiravir have potential for teratogenicity and embryotoxicity. Ivermectin, which is given in few centers, has known to cause teratogenicity in mice and rabbits, and the safety is not established in pregnancy and lactation. Tocilizumab, casirivimab, imdevimab. Adverse pregnancy outcomes like preterm delivery, miscarriage, and anomalies have been seen with these drugs. So you have to be careful. Again, the risk-benefit ratio has to be weighed before giving these drugs. Steroids are safe. COVID-19 and coagulation. We all know that pregnancy is a prothrombotic state. There is an increased generation of thrombin, as well as increased intravascular inflammation. In that patient, this infection can exaggerate this thrombosis. Patients can get thrombotic microangiopathy, and that can affect the brain, heart, kidney, and sometimes even the placenta. Thrombocytopenia is seen even during normal pregnancy. However, in COVID-19 patients, you can have thrombocytopenia. We have seen lots of cases coming with 60,000, 70,000 platelets, and a recent platelet count is needed before you can take the patient for a cesarean section, because you need to decide the type of anesthesia based on this. Subclinical DIC can occur. Decreased mobility of the mother near term may predispose them to venous thromboembolism. So which means if you suspect, because the mother is not moving around. So these are the patients who can have venous thromboembolism because of their decreased mobility. They do not walk around. So maybe you can have a POCUS with use an ultrasound and check whether there is a venous thromboembolism, or you can do a thromboelastography to know whether patients have developed thromboembolism. Again, what about thromboprophylaxis? International guidelines to date recommend thromboprophylaxis on an individual basis. Those self-isolating may not need them. However, those with moderate and severe COVID infection, they are the ones who need prophylactic low molecular weight heparin unless birth is expected within 12 hours. High-risk patients may need prolonged treatment with low molecular weight heparin, or if they have, or they may need increasing doses. Again, labor analgesia. What are the things you have to look for in labor analgesia? Should we give labor analgesia in these patients of COVID? There is no doubt, if there is no contraindication to epidural or a combined spinal epidural, early provision of neuraxial labor analgesia with a functional indwelling epidural catheter is recommended, with the goal to reduce avoidable general anesthesia for cesarean delivery and mitigate risks of the healthcare workers. Labor analgesia, if you give, it may prevent hyperventilation and the consequent aerosol generation. Labor analgesia can also mitigate the hyperdynamic response. Epidural or a combined spinal epidural is the choice if you want to give labor analgesia. However, if you're dosing of opioid, you have to do it carefully, because you have to monitor respiratory depression, especially if the SATs are borderline. So if the SATs are borderline, remember you can give. We are only giving 2 microgram per ml of fentanyl. So that is safe, basically safe, but still remember, you still have to monitor respiration in these patients. And what about labor analgesia with IV remifentanil? Remifentanil is going to hit the market anytime now. Remifentanil cannot be given because it can cause respiratory depression. Entanox avoided because of aerosol generation. Again, what about giving NSAIDs? NSAIDs have to be avoided, not only because it can affect the kidney, not just because of that, that's a second reason, because it increases the ACE2 receptors. And COVID, the coronavirus have a predilection to the ACE2 receptors. That is why we need to avoid NSAIDs, and paracetamol can be given safely. About the antenatal care. So please remember, when they come for their antenatal visits, and the patients have to follow social distancing, self-isolation, and practice good hand hygiene, regular sonographic assessment of fetal growth and well-being, because they have a potential to develop IUGR and placental insufficiency. It's not been proved, but a potential is there. So you need to look out for this. A cesarean or a vaginal delivery, what can happen? The mode of delivery should be determined on an individualized basis. There is no standard guidelines or so-called thing that you have to go only for a cesarean or only for a vaginal delivery. Continuous CTG monitoring should be offered to these symptomatic patients in labor. So the anesthetic preoperative evaluation of these elective cases who are coming for cesarean. So remember, generally in our setup, our patient, we don't go to the ward with our PPE and check the patient. The patients come and we generally check the patient a couple of minutes before the patients are taken in, because all of us are donning PPE. The staff attending to these women should be provided personal protective equipment, which is a level 3 PPE. So what is a level 3 PPE? It is impervious bodysuit, medical gown, a double medical glove, eye protection shield, full face respiratory protective device or hoods, disposable surgical caps and surgical masks or test fit N95 masks or respirators and foot shoe covers. So many times in many big centers, video conferencing is encouraged. So you have a video call and then you ask the history, you evaluate and monitor, and you can also do the handovers using a video conferencing call. Anesthetist should take a detailed history and conduct a thorough physical examination. Particularly, if possible, you can do a focused lung examination instead of a chest examination. So that will again reduce the aerosols which can affect you. So in elective cases, early detection and treatment of hypoxia is important to prevent fetal hypoxia and distress, which is an indication for an emergent cesarean section. Even with a gloved hand hygiene must be performed after contact with each patient. And at the end of a shift, cleaning and disinfection is done by thoroughly wiping the surface of furniture, equipment, and floor with 2 to 3% hydrogen peroxide. So what about the operating room? So the pre-operative preparation in the room. So many rooms have a negative pressure operating rooms. If it is unavailable, at least there has to be 12 air exchanges in an AC operating room. Only personnel involved in direct care should enter the dedicated operating room, which means you have a good, highly qualified anesthetist who has got a lot of experience and a person who's helping you, maybe a resident, and a runner who's waiting outside for help with additional equipment if you need it. Anesthesia machine is dedicated in the operating room with proper disinfection between cases. HEPA filter is between the endotracheal tube and the circuit, or between the workstation and circuit, or maybe all of them, inspiratory, expiratory limb, as well as between the endotracheal tube and the circuit. Some people use three HEPA filters. Use disposables. If a non-disposable equipment is used, cleaning and disinfection should be conducted after completing each case using ethylene oxide or hydrogen peroxide. The increased minute ventilation of pregnancy may increase the chance of droplets spread, and hence even suspect patients. You know, some pregnant women are coming directly from the SARI ward. So those suspects also, even if you're doing a rapid antigen testing, the patient should wear an N95 mask. So this is how we cover the anesthesia workstation. Donning, remember you need to have a donning which is properly monitored. So there is a step to don, how you don your PPE, and there is a person who's monitoring all that and helping you out. And this is the HEPA filters, which is seen in the limbs. And here, this is the one which is between the patient and the circuit. So coming to the most important part is the management. So a categorical sentence, which I'm going to say is spinal anesthesia or a combined spinal anesthesia is to be preferred over general anesthesia. And you can ask me why. Because the choice of anesthesia is dictated by the urgency of the cesarean section rather than the sero status of the patient. spinal anesthesia is still recommended as the primary choice of anesthesia for cesarean delivery, especially in patients with pneumonia. So in those patients with mild and moderate, when I say moderate, I'm talking about a patient who's on some 10-15 liters of NRBM, not a patient who is on NIV. So these are the patients we can give spinal anesthesia. General anesthesia is not preferred because it causes increased aerosolization during pre-oxygenation, face mask ventilation, endotracheal intubation, oral or tracheal suctioning and extubation, and during extubation. Also, there is risk of acid aspiration, iotocaval compression. You can have a difficult airway. So many risks which are seen with general anesthesia is the same with COVID patients. So in spinal, when you're choosing a spinal or an epidural or combined spinal epidural anesthesia, remember the patient is wearing an N95 mask or a 3-ply mask all the time. In case supplementary oxygen is needed, the oxygen mask is applied over the surgical mask or the N95 mask. There should be no overzealous preloading, co-loading in these patients. If the baby is coming down after your spinal anesthesia, use a vasopressor if necessary, but don't keep pushing fluids. Prophylactic antiemetic administration should be done to avoid retching, vomiting, etc. Obvious, because we don't want any aerosol generation. However, remember, even if you're using ondansetron, QT prolongation can occur, and especially in a patient with a preoperative ECG with a QT prolongation, or a patient who already is on azithromycin, HCQ, etc. with a QT elongation, do not try to give a ondansetron. In these patients, dexamethasone is a better alternative. However, you know that the other problems with dexa, we can deal with it because we can give antibiotics to combat the infection which can occur. But then remember, look at the ECG before having a choice of your antiemetic drug. A single shot 2 ml hyperbaric bupivacaine with 20 mics fentanyl. This is what we have been giving and using a thin spinal needle. And post LSCS pain, we give generally paracetamol, but you can also give tab block. You can, if the patient has CSC, you can give epidural analgesia in these patients. All of them are good for the patients. Well, how do you give general anesthesia? There are many questions. What are the challenges of general anesthesia in these patients? General anesthesia, remember, as I said, my choice will be neuraxial, only neuraxial. But if general anesthesia, it can be used as a backup plan in case spinal anesthesia fails or intraoperative conversion to general anesthesia is indicated in these patients, or if there are obstetric indications like abruption, patient is having cardiomyopathy, or a cardiovascular compromise, patient is having severe COVID, patient is on inotropic support, patient is having severe ARDS. So these are the patients whom I will look at giving general anesthesia. The Society of Obstetric Anesthesia and Perinatology has recommended avoidance of emergency deliveries in COVID-19 parturients as much as possible. So the decision of taking the patient for cesarean has to be done earlier by the obstetricians than later, because it takes time to wear your PPE. It takes time for you to go, and then, we know general anesthesia is aerosol generating. We know patients have so many comorbid conditions. Patients are having tachycardia. Patients may have other systemic involvement. So, patients can have superimposed, what do you call, so other superimposed problems, comorbidities, kidney injury, cardiac injury, preeclampsia. Patients can come have a barrage of conditions associated with COVID. So with all this, you may, and patient, you may need to take the patient and give a fast, you need to induce the patient very fast. It is not possible to wear your PPE and come in so fast. And to induce the patient very fast is very difficult. So a decision of taking the patient by the obstetrician should be done early. Keep emergency equipment and drugs ready like stylet, bougie, LMA, a flexible video endoscope, cricothyrotomy set, or a mini tracheostomy set. As usual, nothing different. You need to have an anti-aspiration prophylaxis, pre-oxygenation using an oxygen mask over the N95 mask. Some people are asking whether you can give HFNO. Can you use HFNO in these patients? Well, if you can achieve good saturation only with pre-oxygenation using your boils or using your anesthesia workstation, you don't have to give HFNO. HFNO is an aerosol generation equipment in any case. However, if that small amount of CPAP is keeping the patient saturation good, then you can use HFNO because all of us are anyway donned the PP. Left uterine displacement. Be aware that the adequate mask seal and minute alveolar ventilation is before intubation is done. So the mask seal is very important because again, we want to avoid aerosol generation. So if high flow oxygenation is required, the provider should be cautious as high flow oxygen increases the production of viral droplets and aerosols. You need to adopt a modified RSI. Many times, if you do not give a small ventilation with your RSI, sometimes the patients can desaturate very fast. The margin of safety in these patients is quite less. So you need to adopt a modified RSI. What is your choice of induction agent? Propofol, etomidate. Well, I put a question mark for etomidate. Why? Because you don't know whether these are the patients on steroids. So you may have to give steroids at induction. They may have an obtunded hypophyseal adrenal axis. So if you're using etomidate, then you are tickling that. So we don't want to use etomidate. So ketamine based on the hemodynamics. If the blood pressure is on borderline 100 or 90s, or if the patient is on inotropes, we'd rather use ketamine for induction. Sufficient muscle relaxation should be obtained to prevent coughing, bucking during intubation to minimize the aerosol generation. So ensure that muscle relaxation is complete. As I said, apneic oxygenation time is very short and you need to avoid severe hypoxemia in these patients. So if you can give low volume breaths, as I said. Oral intubation with a video laryngoscope and preferably with a disposable blade is preferred. And if you can have a separate monitor of the video laryngoscope, it is even better. Intubation should be performed by an experienced anesthesiologist assisted by another clinician who can be even your junior in order to minimize the number of attempts and production of airborne material droplets from these patients. So this is a picture to show using using your video laryngoscope, and you can have a separate monitor. It is even better. Again, if you encounter a difficult intubation, don't hesitate to use a second generation LMA. And if you have a failed intubation, FONA should be done using a scalpel bougie tube technique. Try not to auscultate to determine the equality of ventilation after you have put in the tube. You've used a video laryngoscope and you have put in the tube under vision. And then you don't, with your PPE, it's difficult to use your stethoscope. See the chest expansion and see the ETCO2. You've done now intubation by actually seeing in the monitor. Then when you're giving ventilation, use a lung protective strategy, which is used in the ARDS-NET ventilation protocol. And that is a tidal volume of 6 ml per kilogram having a P-plat less than 30 centimeter of water and enough PEEP to maintain a PaO2 of between 65 and 90 millimeter of mercury. Sevoflurane is very safe, fentanyl is given after delivery, and oxytocin also is given after delivery. So for the critically ill patients with COVID-19 pneumonia, these are the patients under general anesthesia. If you don't take proper precautions and minimize hypercarbia, hypoxia, and acidosis, they may develop severe pulmonary hypertension. So you need to avoid pulmonary hypertension in these cases. A closed airway suction system, if available, is recommended to reduce the viral aerosol production. If not available, minimum suctioning should be done. Extubation should be done without coughing and bucking. Remember that. Again, we do not want aerosol generation. So what about severe cases? So these are the cases who have renal involvement, liver functions may be deranged, neuro involvement, they may be obtunded, cardiovascular involvement, they may come with a STEMI, they may come with arrhythmias. So based individually, you can decide whether you want to give general anesthesia or neuraxial anesthesia. So those who are having who are on low molecular weight heparin, therapeutic anticoagulation is withheld for 24 hours, and if it is prophylactic, at least for 12 hours. Renal and liver functions may be deranged. Still, if the coagulation profile is normal, platelets are normal, I would still give neuraxial anesthesia in these patients. If the patient is obtunded, there are no two ways, you have to give general anesthesia. If the patient has had a STEMI, or if the patient has had myocarditis, or patient is having dangerous arrhythmias, then these are the patients who need general anesthesia. We cannot take the risk of a patient who has had a recent coronary thrombosis to give regional anesthesia. Well, you can think if the coagulation profile is normal, then you can think of giving, and if all the cardiac part is settled, then you can think of giving combined spinal epidural, a small spinal, and you can advance it with your epidural. But again, it's all case to case. There is no standard thing that, in this patient, you have to use only this. You have to see case to case and then only decide about it. At all costs, you have to avoid hypotension in these cases. So remember that. Step up your hemodynamic monitoring, especially if there is multi-organ involvement of COVID. You please remember steroid cover has to be given because the hypophysio-adrenal axis is suppressed. Blood sugars, many times, these are patients are on steroids and they may get pregnancy diabetes or diabetes because of steroids. So many times you may find patients may have uncontrolled sugars. So you need to monitor glucose in these patients. You have to give insulin. And optimal pre-oxygenation, I already said, HFNO if required. And I said ketamine if the patient is on inotropic support, and 100% oxygen until delivery of baby, and addition of compressed air to maintain SATs of more than 95% if you're using general anesthesia in these patients. So what about recovery? Before extubation, a 2-layer of bed gauze can be placed to cover the patient's nose and mouth to minimize exposure to the patient's secretion during extubation. Last year, we used to use these intubation boxes and plastics. We found it too cumbersome and impractical. So we've become bolder now. We do not use them anymore. And except that we are completely protected by our PPE. So we just use a gauze over the patient's nose and mouth and we extubate the patient. So, and we do, and closed suctioning. And if closed suction is not available, then we have a gentle suctioning, and then we extubate the patient quite without allowing the patient to buck. So these patients are sent to an isolation room in the ICU after surgery, bypassing the PACU for observation. Remember, the risk of infective airborne droplets is there to the baby. So it's preferable to keep the baby little away. Use of breast pump for feeding is a good option. There is no risk of transmission of the virus through the breast milk though. So breast milk is very safe and it has to be given to the baby. What about the waste disposable and the equipment care and operating room disinfection? So single-use anesthetic equipment exclusively, especially for those with direct contact with the patient's skin or mucosa, including the video laryngoscope blade, reinforced tubes, masks, filters, suction tubes, catheters, all of them, expiratory carbon dioxide sampling tube, water traps, etc., has to be discarded into a bag where you can have Lysol. All anesthesia equipment should be cleaned and disinfected promptly. The carbon dioxide absorber is recommended to be replaced between the cases as it provides a large surface area in the anesthesia machine. The surface of the anesthesia machine, laryngoscope blade, and other non-disposable equipment such as transfer bed trolley should be cleaned and disinfected with 2 to 3% hydrogen peroxide, or you can use an alcohol, 75% alcohol wipe after completion of each case or at the end of each shift. So doffing, as much as donning is important, doffing is even more important. All healthcare workers participating in this case should have a doffing area with a designated waste bag in that ante room. So there is a certain order of doffing. All of us have heard this multiple times. I'm not going to repeat it. Again, there is no evidence of a spontaneous preterm, pre-labor, rupture of membrane or stillbirth in a patient of COVID-19. So there is also no evidence to suggest that COVID-19 is teratogenic. No increased rate of miscarriage or early pregnancy loss in relation to COVID-19 infection. There is no evidence of increased blood loss. There is no evidence of vertical transmission to the newborn. There may be 1 or 2 cases where you find that the babies were born with COVID, but the larger information is in the last 2 years, there is no evidence of vertical transmission to the newborn. And the neonatal birth weight and Apgar scores are not affected, and complications are not observed in the newborns. Fetal bradycardia with regard to the possibility of fetal distress can happen, but that can happen not specific for COVID. Neonatal transpharyngeal smeared amniotic fluid, umbilical cord blood, placenta and breast milk samples have been shown to be negative for this virus. Stillbirth with no clinical or serological evidence suggestive of vertical transmission of SARS-CoV-2 virus. As I said, it has not been proven. So to complete my lecture, I just want to give a crisp retake on what I already said. If you have a patient, admit if necessary, isolate, swab, use appropriate PPE, ensure a multidisciplinary approach, CTG monitoring, full blood count, do the barrage of all the tests which I already told you, oxygenation if required, fluid management, nutrition care, paracetamol, anticoagulation, azithromycin, HCQ. That's your hospital protocol. What you want to give, what antibiotic you want to give, that's your hospital protocol. And assess the need for corticosteroids for the fetus. If the CTG deteriorates, fetal or maternal indication for delivery is there, go for a neuraxial anesthesia. If the clinical condition worsens, you have to admit the patient in the ICU, IV fluid strategies, antibiotics, invasive ventilation, lung protective ventilation, prone ventilation, or ECMO. All that will depend upon how severe the parturient is. And if the baby is rooming in, please understand you have to at least have 1 meter distance. And the baby has to be at least 1 meter distance from the mother You can put a mask on the baby also. You can have a mask on the mother also. And remember to have a surface disinfection. And a retake on your labor analgesia. As I said, there is no evidence that epidural spinal analgesia or anesthesia is contraindicated in these patients. So epidural analgesia, in fact, is recommended in these patients. So please remember, always check for thrombocytopenia. If it is there, then you can give labor analgesia. If there is no thrombocytopenia. And as I said, no Entonox and no remifentanil. For cesarean delivery, again, repeat, neuraxial anesthesia, avoid general anesthesia for all the reasons I told you, and donning a PPE and doffing the PPE properly. And please remember, even if it is such an emergency cesarean section, you need to wear your PPE and going. See, all these are not our guidelines. These are guidelines from all these multiple societies: Obstetric Anesthetic Association, Royal College of Anesthetists, Association of Anesthetists, Intensive Care Society, Intensive Care Medicine. All of them have given these guidelines. And general anesthesia, as I said, it has its own challenges. PPE can cause communication difficulties. And if possible, as far as possible, don't use HFNO. You just use an oxygen mask over your surgical mask on the patient. Intubation, use a video laryngoscope. And in case of a difficult intubation, you can use a second generation LMA. And as I said, scalpel bougie technique for fauna. And so double glove, and then, wash your hands. Then don't try to auscultate. Anyhow, you have done intubation with your video laryngoscope, so you have seen everything, and you can look at the chest expansion where the bilateral expansion is normal, and look at the end-tidal carbon dioxide. No need to auscultate this patient. And extubation, again, as I said, is a high-risk aerosol generating procedure. See to it that the patient is not coughing on the tube. Okay, so these are the basic advice. And again, you can have simulation training if possible in your hospital. If it is available, go for a simulation training, practice donning and doffing, and you follow your hospital local protocol and recommendations, and familiarize yourself for all these protocols. Thank you very much for your patient hearing.
Thank you, madam. That was a thorough and complete presentation, and you have covered almost all areas, but still there are a lot of practical questions in the chat box. And madam, you want to answer those questions, or you want to hear some from the expert panel? You have a panel and you have certain questions to clarify, no?
We can, I don't mind anything, but if you want, we can, the expert panel also can answer the questions.
Yeah, that will be fine.
Right?
Yeah, you can go ahead with your experts panel, madam.
So Rajesh, I don't have the questions. I just need to look at the box. Otherwise, what we do is, wait, let me see.
So this the first question is, what difficulties can we have on endotracheal intubation in COVID pregnant patients, in addition to difficulties in the pregnant patients? And I mean the question.
The difficulty is not different from any other patient. So the only difficulty is only because you, an expert has to be there to do the intubation, because we don't want re-intubations. It's an aerosol generating procedure. So ensure that muscle paralysis is complete and patient is not bucking on your tube. Use a video laryngoscope to intubate the patient. You ensure that you are completely protected with your level 3 PPE. That's all. The difficulty is not different from any other, parturient.
Madam, you use the box, aerosol box, or
no, we don't use it.
Or the transparent
we stopped
sheet?
it. We stopped it.
Okay.
Last year it was very famous, but this year we are not using it.
Okay.
I agree with Dr. Indrani, and Dr. Indrani, she has given a very, very elaborate, and she has covered practically everything which is possible for the COVID in pregnancy. That was a fantastic talk. It covered everything. So whatever little doubts are there in the chat box, I think she has answered everything. But still we can take on the questions if there is any more doubt. Even we are not using the intubation boxes. I don't think anybody else is using. And the reasons are very clear, as Dr. Indrani has said, they are very cumbersome.
And are you using the video laryngoscope or the ordinary laryngoscope?
We are using
Video.
video laryngoscope.
Forget COVID, even non-COVID, we are using video laryngoscope.
Okay.
The practices have changed now to, video laryngoscope. Yes, correct.
Yeah.
So safety is more important than anything else. And safety of the healthcare workers is also important. So when we talk about COVID, it is not only the mother, it's also the healthcare worker, as she has very correctly pointed out at many places, that you need to be very careful what you wear and go. You have to be careful both about the mother as well as the healthcare worker. Am I correct, Indrani? That's
very, very correct. And channeled video laryngoscope. If you're expecting any difficulty, if you feel the mother is too obese, short neck, or you're expecting some difficulty, use a channeled video laryngoscope. That increases the success rate.
And
any other, what other questions? I'm just trying to see.
So there is a query from regarding the CT in pregnancy. What precautions will you take?
CT means what? CT scan.
Chest,
CT
CT
scan.
chest, I think.
CT chest. I have an abdominal guard, no?
Yeah, that you have mentioned.
That can be done with an abdominal guard. So you can do it.
Okay.
See, and only in symptomatic pregnant patient, highly symptomatic pregnant patient. See, if the patient is, you have to at least wait for 4 to 5 days. By the time the cough and the fever settles, you don't go for CT. And if the saturation is maintained at 90 up to 94, don't go for CT. Only if the saturations are on a decreasing trend to less than 94%, that is when I will go for CT. Otherwise, no CT.
Correct. There are definite indications for doing CT. CT is not done even in our institute. Like we do not recommend doing a CT for all patients. It's not recommended.
Yes.
I think Anju will also agree.
Yeah, absolutely. CTs, as ma'am very correctly pointed out, it is only to be done in specific indications where patients are becoming progressively hypoxemic. Yeah. An excellent talk by you, Dr. Indrani. Congratulations.
Thank you so much. Thanks.
So what about the comments from Dr. Anil Satyadas? Dr. Anil was there from the first case onwards in the Trivandrum Medical College. Dr. Anil?
Yeah, good evening all. So I usually handle critical care. So it would be category C with dependent on NIV and things. The most important problem or confusion we have is when to terminate the pregnancy. Gestation is less than 30 weeks. And the patient is dyspneic and depending on the NIV. And like in other cases, non-pregnant cases also, we have like a dilemma whether to intubate the patient or not. There are some studies showing that intubation is almost same to NIV. And in this pandemic era also, we find it difficult to maintain patients on IMV intubated, and they go for secondary sepsis by the end of the second week. So termination of pregnancy, this decision is very, very difficult, especially when we don't have facilities for neonatal care. That is one aspect. And also second is when to intubate. So these are the problems. Otherwise, we have managed around 250 cases last month. And out of that, 40 cases were category C, and we had three mortality.
Dr. Satyadas, I would like to bring to your notice one more thing. See, these patients, NIV is not equivalent to intubation, number one. So, and these are the patients whom you feel that the PF ratio is falling less than 150 after maximal oxygen support, I think the patient needs to be intubated. There are no two things about it. Patient has to be intubated. Coming to the decision of whether we have to abort, I mean, we have to get the child out, right?
Yes.
Get the child out.
Yes.
Again, that's an obstetrician's, decision to get the child out. But as an intensivist, you can say if the child comes out, this mother has got better chance of survival. So, in fact, I've been struggling in my institute because my obstetricians are very, very conservative when it comes to this. And I literally, because I'm part of the critical care committee, and I keep saying, and I show them, various publications where it says that, you have to deliver the baby. No, they are not convinced. And we have lost mothers. We have lost mothers.
Yeah,
so, you are very right. I mean, but then it is on the purview of an obstetrician, and the obstetrician has to take this decision well in time.
Yeah, we have been lucky enough to. Yeah, we've been lucky enough. Meena, I think you should have more of interdepartmental meetings and kind of discussions, which perhaps, yeah. But then, of course, the mindset does make a difference. I agree with you. But we have been lucky enough to have obstetricians who have been aggressive, and indeed, it does help.
Yes. I also think there should be a team who should decide on some sections which are, very controversial. Like there's a risk of death to the mother. Basically, the obstetricians are scared because there's a maternal mortality, and that comes into the maternal review board. So everybody wants to justify why that mother was taken in, and whether not taking her could prevent her death. So that's one big question. So when we sit in an interdisciplinary way, maybe we can sort out these issues, because it's very difficult to say, yes, this mother will benefit from section, and
Kajal,
yes, this mother may not benefit from section.
Yes, Kajal, ours is the critical care committee is an interdisciplinary committee where we have one person from each, so, but then in spite of it, they are not convinced.
Absolutely. So the message should go from this meeting is this only, that certain decisions are very difficult to take, and it all depends on case to case basis. Right now, there are no guidelines or recommendations to tell us that yes, this mother will be benefited in view of severe hypoxemia, impending ARDS, or refractory sepsis. Like this is a mother who will be benefited from a cesarean section. We cannot say that as of now. We need more data on that. Is that not correct?
Very true, very true. And also that even if cesarean section is done, we are not gods. We are not going to say that this mother is going to, to survive.
Yes.
That is a small iota of, we're giving her that small thing that she can come out of it.
There is one term which has come as agonal C-section. I think some of us would have heard about that. Like resuscitative hysterectomy, they have also given one term about agonal C-sections, the ones which are like life-saving for the mother. So right now we do not have them in our guidelines, so we can't talk really much about them. As of now, what Dr. Indrani has pointed out, and she has put in her slides, is the current literature and current evidence, and what is recommended to be followed.
What about the comments from Dr. Sunil Pandya? Sunil is there?
We had to go for some hospital emergency, I believe.
Okay. Dr. Lynette Madam was there. Actually, Lynette Madam was the one who initiated this discussion. She was Madam was suggested this topic. Okay. So there is another query regarding the various drugs used for the treatment in COVID and their intrauterine transfer to the baby.
I think Dr. Indrani covered them very well.
She has covered them
in the slides. Yeah, she did cover.
And what about remdesivir? It is yet to be approved by ICMR, no?
That's why I said remdesivir doesn't cause any fetal problems, but then remember that it causes liver dysfunction, renal dysfunction. So you have to see the risk-benefit ratio. You can't You can't swear and say that this mother, all mothers should get it. All the moderate ones who are on high oxygen therapy should get remdesivir in the first week. I agree to that. But moderate COVID should get it. But then again, look at the risk benefit and then decide. See, you also remember COVID mothers can have preeclamptic toxemia. They can come with preeclampsia. They can come with high serum creatinine because of preeclampsia. In those cases, can you give remdesivir? You can't. So you have to weigh the risk benefit when you're looking at remdesivir.
So this COVID patients, they have a sort of hypertensive tendency, no? So how to deal with it when you give general anesthesia? That is one query.
Hypotensive or hypertensive?
Hyper.
I think that doesn't
We
differ
have
between
not found
non-COVID
anything.
and COVID. There is no
Okay.
difference.
No
Only thing
difference.
No difference. Okay.
No difference.
So what about the use between dexamethasone and methylprednisolone, which is better? Because we are that's another query, because we are worried about the sharp increase in blood pressure with prednisolone.
Actually, after the recovery trial, people have shown benefit of Dexona over methyl. So Dexona has got a scientific evidence. If you want to convert it to equivalence, you can convert. But right now, Dexa is more important to remember is that Dexa should be given only when it is indicated, because there are stages of this COVID, disease infectivity period. So you should know when you should give. Like somebody told me the other day that all obstetricians, if the baby is like, if you give it for lung maturity, you should also remember that at certain infectious, part of the, course of the disease, Dexona is not indicated because it flares up the disease. And it contributes to maternal, sepsis, and it causes adverse outcome of the mother. So more important is to remember these points as well, rather than to convert from methylpred to Dexona to prednisolone. You can remember the equivalence if you don't have, but recovery trial has given us an insight that Dexona is good.
Okay, madam, thank you. So what about the respiratory compromise in the post-COVID recovering pregnant patients?
Respiratory compromise?
Yeah.
I
That
think
is
it
one
was
query.
Post-COVID patients, that's what you are trying to say.
Post-COVID patients, yeah.
Oh, it's not difficult. It's not different from any other patient.
Exactly. It's the same as the other patients. You have to check for their, saturation. If the saturation is low, you have to.
Management is the same.
What about the disinfection and maintenance of the workstation and?
She's already.
I already covered. I told you,
shown in
use a
detail.
75%
that was there in
alcohol
the slide.
wipe, or you can use hydrogen peroxide. You can use Lysol. You can use anything.
So Indrani has covered it beautifully. She has covered each and every aspect,
Yeah.
and she has taken all guidelines,
everything is
RCOG and soap and everything. So I don't think she has left any scope for any doubt.
And
And use of apixaban
madam
tab.
is there.
Sunanda ma'am is there.
Yeah, she's
Good
there.
evening,
Any
ma'am.
comments?
Good
Sunanda
evening,
madam?
ma'am.
Hello,
Sunanda madam
ma'am.
is-
Good evening, ma'am. We'd love to have you.
Madam,
No
we want to
comments.
hear you
And see you.
and see you.
Where is she?
I was just hiding. I said such luminaries sitting on the dais. I didn't want to barge in,
You're the doyen, ma'am.
Oh my. Indrani, that was a beautiful
I'm
lecture.
happy. I came to know that you are in after I finished my lecture.
No, ma'am was there. Right.
You would have been intimidating to me.
I came 5 minutes before. Yeah.
Oh, no.
Ma'am,
So
anything you would
Indrani,
like
there
to
was
add?
a question in the box,
Hmm.
which I think Rajesh was talking about. Do you need to have some extra precautions for patients who already have iron deficiency anemia, considering that these patients are more prone to postpartum hemorrhage and like you said, the coronavirus directly affects the receptors. So they are more prone to hemolysis also. So would you give the audience some clue about what else to do in these patients?
Ma'am, the literature clearly says that there is no increase in incidence of postpartum hemorrhage in COVID patients.
Okay, there was a 2020 meta-analysis. I think, Kajal, you have that?
Yes,
She
ma'am.
has that. Yeah. So there were some concerns about the increasing ferritin levels and, because of the acute infection. So would you like to give parenteral iron in these patients when they are affected with COVID-19 during pregnancy? So there's a lot of debate going on that would you like to give your parenteral iron, because iron is known to replicate the virus inside the host cells. It supports replication of the virus. So there's a lot of controversy going on these, and actually there is no consensus yet about it.
But I believe, ma'am, that iron therapy, on a kind of just a general sense, would probably not be a very good choice in these patients, considering that you predispose them a lot to many other infections as well.
Come again,
Especially with
I
mucor
missed
coming
out.
in, yeah. I'm not very sure about this, but then.
What is that you were saying?
I said I would rather like to defer giving parenteral iron therapy during active COVID infection.
Anju has a point, ma'am, because mucormycosis and mucormycosis, they have said like the increased ferritin levels are also one of the contributing factors.
Very big.
As the COVID virus, it has got some receptors for attaching these ferritins.
And on
So
the other hand,
it takes food from those ferritin.
Yeah, I agree. And on the other hand, it's like, between the devil and the deep sea. On the other hand, you have the problem of decreased oxygen transport and tissue ischemia because you do not have your hemoglobin there.
So
Dr.
I don't
Sunil
know.
Pandya,
Rather give a blood transfusion.
Blood transfusion. Yeah, that's what I was about to say. Yeah. We have had cases where we had PPH during with COVID mothers, and we preferred going in for blood product transfusions rather than.
Yeah, I think that is a much more safer option as compared to your parenteral iron.
So there's another question. The comments. What's the choice of anesthesia for MTP?
We have shifted
Medical
to
chemistry.
regional anesthesia now, and we prefer and we have convinced our obstetricians, and we do a saddle block.
Correct. Absolutely correct.
So comments from Dr. Sunil Pandya is there. Sunil?
He has
Dr.
left
Sunil?
for a hospital emergency. So
okay.
Yeah, he just passed on a message to us. Yeah. He's indeed giving an epidural to a friend's wife right now.
Okay, yeah. So how to deal with the patients with the low molecular weight heparin or oral apixaban with the high D-dimer values? That's another query.
Apixaban, I think it has got a half-life of about 72 hours.
12 to 72 hours, somewhere like that. But
something like that. So the half-life has to be, you have to wait for that.
There is no difference, I guess, from the other non-COVID patients. There is no difference.
This is a 10A inhibitor. So
72
low
hours.
molecular weight, I already said. Therapeutic, it is 24 hours. Prophylactic, 12 hours.
12 hours.
So a kind of a message here is that to your obstetricians, you should tell them to prefer putting patients on low molecular weight heparin because that's more easily titrable.
Instead of
than,
apixaban.
other newer anticoagulants.
Are there any mucormycosis cases in your experience? Any of the experts? And
in parturients?
Yeah.
No.
No. Otherwise, no, not really.
Otherwise,
yes,
but
we have
not in
many cases.
So even if the patient is on oral anticoagulants in the first and second trimester, they can be converted to low molecular weight heparin towards the
they should
of pregnancy, or even unfractionated heparin.
Yeah. There was a very interesting, an important question, I believe, since we have a large audience, is since you're in a private practice and you have a hospital which does not have a level 3 facility, should we go ahead and conduct a cesarean section for these? I would rather say it has to be a very cautious approach, preferably a no. should shift the patient to a center which has a backup of a level 3 COVID care facility up there. These patients are known to progress, and especially in the second wave, we have seen that patients have progressed by the second week into severe hypoxemia and poor mortality, very high mortality. So that's better.
So the ICU backup is very important. That's actually another question. Can we give LSCS in a setup without ICU?
You are calling is not answering. Please call again later. आप जिस एयरटेल
Please
सब्सक्राइबर
unmute.
को कॉल कर रहे हैं
Hello.
वह अभी कॉल
Yeah, what's the question?
कृपया कुछ समय
Dr. I think Dr. Anju madam has explained. Very nicely
And there was
that the
one
question
more,
was,
there was one
can
more
we
question.
give?
There was one more question regarding post-dural puncture headache. Somebody had asked. So I think the guidelines are recommending the usual standard treatment, only that the newer modality which has come up, the sphenopalatine ganglion block, has
That
been,
should be avoided.
that should be avoided, because
yeah.
it causes like irritation and aerosol generation. Otherwise, blood patch is not contraindicated, and the usual conservative managements are as for the non-COVID patient. So somebody was asking that question too.
So how to differentiate between a drop in SpO2 due to other non-COVID reasons like amniotic fluid embolism or any other reasons?
Any embolism, you will find a sudden fall in saturation and a sudden fall in hemodynamics. Whether it is, you think of embolism only, first thing. If the saturation at 95 went down to 30 suddenly, think it is an embolism.
That it will be more catastrophic and sudden.
Yes.
So whether it is thromboembolism, whether pulmonary thromboembolism, whether it is air embolism, venous, whatever, but it is an embolism.
So what's the dose of dexamethasone you gave pre-op?
We are using 6 milligram OD, the same as has been recommended.
Okay.
We can't hear you, Dr. Rajesh. Yeah.
Yeah, sorry. So have you experienced a problem with the monitoring CO2 at endotracheal? I don't think that's a difficulty because we use HEPA filters.
No.
Routinely used. No? How many HEPA filters do you use? One at the patient end and one at the mission end?
Yeah,
Yes,
two.
yes, correct.
Yes, sir.
Two.
Even sometimes people use 3.
3 as well. Yeah.
Yes,
We are using only one.
okay. So any comments from Anil Satyadas? Is Anil? Anil, hello? Anil or Lynette, madam?
Can I ask few questions
Anil is not there.
to our eminent panelists? And of course, madam is also there. So much about video consultation. Kajal, do you do video consultation?
Yes, yes, totally. It's on.
What about you?
Especially now, the obstetric colleagues are doing video consultation since the last year only. And we are also running our PAC clinic and all those things on video. We are doing. Even home consultations for patients, it's on. As much as you can avoid the direct physical contact, it's recommended.
Yours is a high-class patients. Our patients don't know how to use a video also. So
No, even we are facing a lot of problem there.
So what we do have
low
is
socioeconomic status patients are facing difficulty.
So what we
then
do
that's
have
it.
is, one of the options that we have in our hospital is that we have adopted a system. Fortunately, we do have many of our anesthesia postgraduates in majority of the COVID ICUs. So if the patient is being posted or is being scheduled, one of us will don and go in. And then of course they can use a video to transmit it to your senior, and a complete PAC is being done there with the consent taken, so that there is no delay or in the preoperative areas.
See, for in-house patients, even we have a team. For in-house patients, we have a team who's dedicated. There are rosters which are changed every week. So they are divided into 2 to 3 shifts depending upon where they are posted. Like in obstetric unit, we have a 12 hours running service for a COVID and non-COVID, cesarean sections. and there is the entire team is different. So as Anju has said, they'll wear an impervious gown and they'll wear their mask, and then they'll wear their gloves, and they'll go and do a pre-anesthetic checkup if required. That is being done.
Tell you very frankly, our patients are seen 10 minutes before. We don't have a video conferencing.
You may be right, because these are
Sometimes,
just,
yes.
it is not that we are following it hard and fast. Whatever you are saying, I don't think we all differ in that in any part of India, because our systems, you know how our systems work. So sometimes we have to go in like how you are saying, but mostly we would like to, you know, if there is a team deputed, but if they're not busy, they can go and see. If they're busy, then of course 10 minutes prior, as you are saying.
Guidelines talk about ultrasound lung assessment, right? So don't auscultate.
Yeah.
We always auscultate. That's the problem. So what about you people?
No, in our center, like I see residents using lung ultrasound, but they do auscultate. They all have stethos around their neck. Even if you go around and you say there is a stetho around their neck. So many times I've seen some of them, they do carry their stetho. But yes, because not all of us are used to doing focus and seeing whether endotracheal tube is in place and whether we can check the bilateral air entry, or we can identify B lines, and sometimes a junior resident is posted. You know how we are utilizing the strength. The junior most also goes to COVID, so it's all like the just joined MD, maybe 2-3 months down the line is also going there, so he would know how to do it. Definitely, there are sometimes there is a problem, but ultrasound is there on the floor.
And there is this theoretical, question about that intrathecal seeding of the virus and meningitis occurring after that. Have you had any experience post-neuraxial anesthesia, patient developing meningitis and encephalitis?
Not due to COVID, otherwise we have
COVID. Due to
no,
COVID.
Not yet. Maybe somebody has seen and they can report it, but we haven't seen it. And I haven't read any report either. I don't know about Anju, but before coming, Dr. Sunil is there. Maybe he can tell us. Hi, Sunil.
I had to rush.
It's a difficult, tricky question.
That was fast.
Yeah, that's pretty fast.
I came from home actually. Home April also is over now. Yeah.
And so I was just saying whether there are theoretical things saying that there is seeding of the virus when you're giving a neuraxial block. So have you come across any patient who has had meningitis, encephalitis?
No, basically it's theoretical concern. And they have tested also, and it's for not to worry, because if you look at the concentration of viremia, even at the peak viremic load, even if the CD value threshold is very low, the concentration is less than 0.2% in the blood, in the fluids. So,
and what about, these patients have leukopenia and lymphopenia, right?
Yeah.
So how many of you have seen that? These are the patients who are also immune suppressed.
Yeah.
Right. So how many of you all have seen infection post, post cesarean?
So far, surgical site infection rate has not increased post-COVID. We have not changed the antibiotic prophylaxis. Generally, we give Cefuroxime 1.5 grams stat at the time of
Cefuroxime and sulbactam.
Cefuroxime, second generation cephalosporin. And yes, thrombocytopenia sometimes can be a concern because all viral illnesses can cause low platelets, and our cutoff is around 60 to 65,000, depending again on risk benefit. But suppose if the patient has superimposed preeclampsia or hypertensive disorder, which is an additional risk factor for thrombocytopenia, you need to be very vigilant. And generally, by protocol, whenever the platelets are less than 1 lakh or the reducing trend, we get a prothrombin time and partial thromboplastin time also checked as a baseline, though not mandatory. But infections, lymphopenia and infections, leukopenia and infections, we have not seen any increased incidence.
Not an increased incidence.
Yeah. The regular 0.5 to 1.8% surgical site infection rate. The same thing persists now also.
How many of you all have negative pressure OT?
None of us.
No,
We
I
have,
don't
we have created
We have
one,
a-
but it is just the jugaad which is being done for all of us.
actually just 2 weeks back, we constructed a dedicated COVID theater with -10 pascals. So yes, it is a Herculean task. We try to create negative because each of our OTs are independent EHUs. And initially, during the first wave, we tried to reduce the fresh gas flow and increase the exhaust to create negative pressure. But somehow with the it didn't work out well because it's a big OT complex, 17 OT complex. So we have moved to the basement for a dedicated COVID theater now. But yes, it is a lot of electricity and no increase in charges, no increase in billing charges. Government doesn't allow that.
Sunil, there is one question for you. Somebody is asking about termination of pregnancy in a critically ill mother. They want your opinion on that.
Yeah. See, basically, the indication for cesarean section is obstetric indication, but when the mother is rapidly desaturating and prone ventilation also is not helping. Prone ventilation can be done in pregnant patient. Yes, pregnant patients. And even if the prone doesn't help, then about 24 weeks, do not wait. Terminate the pregnancy, at least debulking the abdomen is going to increase the diaphragmatic excursion, improve the compliance, and possibility of early weaning is there. But generally, whenever we take a decision about termination of pregnancy with a rapidly desaturating mother, because we have the facility for ECMO, we also counsel them because earlier, not in this COVID, but earlier during the swine flu, we have had cases where we put the patient on VV ECMO and continued the pregnancy also. So that option also can be discussed. But by and large, ECMO is not there all around. So my take is terminate the pregnancy if the mother is not able to maintain PaO2 or PF ratios of more than 280 to 300 millimeters of mercury. We need to maintain SATs of 94 to 98, as Dr. Indrani said during her talk. Not less than 92 or 90 as we do in non-pregnant patients. Termination of pregnancy
Dr.
definitely.
Sunil,
Yeah.
Yeah,
How many of you all have encountered diabetic ketoacidosis?
To deal with postpartum hemorrhage?
Yes. See, the thing is, postpartum hemorrhage, the protocol doesn't change in COVID mothers. But yes, we need to be judicious in transfusion endpoints because I don't want to be overzealous FFPs and cryo. So point of care testing is very useful. But if you don't have point of care testing, regular 1:1:1:1 definitely is a good bedside guide. And PTA, PTA and fibrinogen of at least more than 200, 220 is what we target because we don't want to increase plasma fibrinogen to more than 300. Because again, hypercoagulability itself is a major risk factors. In this second wave, we have seen one case of pulmonary embolism and 2 cases of extensive CVT. So hypercoagulability is an issue. So whenever you have a major obstetric hemorrhage, the endpoints of transfusion triggers should be very judiciously balanced.
So Sunil, you use point of care hemostatic monitors like a TEG.
We also use. We have
that's the guidelines for the further component therapy.
Absolutely. In fact, that's I would say a very good bedside care. But again, that it's a thromboelastography also takes about 45 minutes to 1 hour for the entire graph. But initial 15-20 minutes, we know the trend. We know the trend which way we are going. Yeah.
Well, actually, we've had patients who died. Actually, these patients died who had an acute extensive STEMI and pulmonary thromboembolism.
Very common, yes.
2-3 patients had pulmonary thromboembolism, was thrombolized, came with rectus sheath hematoma afterwards, and we have had patients with cerebral venous thrombosis.
Yes.
With hemorrhagic infarcts. And we've had patients with venous thromboembolism. So as you rightly said, the second wave is, it is more of a thrombotic, complication.
And importantly, even asymptomatic asymptomatic SARS-CoV positive, you need to give post-operative or peripartum thromboprophylaxis for 7 to 14 days. If there are additional factors like emergency section or morbid obesity or GDMs or any of those comorbidities, but asymptomatic COVID, better to go for at least 2 weeks of LMWH in order to minimize this risk of DVTs and CVTs.
Sunil, actually, even for non-pregnant patients, so they say that anticoagulation should continue for 3 months.
Yes.
I mean, they're giving factor 10A inhibitors, rivaroxaban or
Yeah.
apixaban or something. They are actually saying you have to give it for 3 months.
Again, because postpartum hemorrhage is always a risk factor. You have to titrate the risk of bleeding versus risk of thrombosis. But majority of the time, after 3 days or secondary PPH, secondary hemorrhage factor is not there, then yes, you can continue for a month or 2 months also. But always go by clinical factors as well. Have a low threshold to continue therapy if you feel there are multiple risk factors.
So have you encountered patients with altered sensorium?
In fact, 3 patients, as I said, all the patients and antepartum, they presented with altered sensorium, loss of consciousness, poor GCS, but pulmonary wise, PF ratios are more than 450 on room. So they presented with cerebral venous thrombosis, extensive CVTs, and we had to terminate the pregnancy because ICP was quite high, and still comatose. We had to do a tracheostomy, but lung-wise, they're absolutely fine. Predominantly neurological involvement. They were on, of course, total therapy.
Actually, I faced about 3-4 patients with postpartum cardiomyopathy. Have you had a spate of them during the COVID?
In our forum of POA, I think Ketan or Shilpa, one of them had this case where uneventful cesarean section was done under spinal. Patient went home, or rather went home the next day on first post-op day, and she came back on second or third POD with breathlessness, and subsequently was found to have an ejection fraction of almost 20%, and landed upon ECMO for cardiac reason. But respiratory involvement also was there. But I think eventually the patient recovered. This was, I think,
yes. Correct. Ketan's case.
Yeah.
We actually in our hospital we had a spate of 3-4 cases with postpartum ejection fraction of 35%, 30%.
Yes.
And what about diabetic ketoacidosis? Have you come across these patients?
Every case of DKA, where even with the sugars of 380 ketones were positive. That could be again because of to an extent people came to from a rural area, starvation, and that could be an element of ketone body is positive. But pH was 7.1, and then she recovered eventually.
What about pre-op fibrinogen level? What's the optimum fibrinogen level you want to keep?
If you see the pregnancy, the level almost 450 to 750, but I would be happy if it is around 350 or 400.
400 is good.
Okay. So, is there a chance of vertical viral transmission?
Yes.
She has already spoken in her slides.
Yeah. In fact, I think we have had 2 cases here in Hyderabad, not in our hospital. 2 cases in Hyderabad where they reported vertical transmission. And I think Kajal also had a couple of them at PGI.
Yeah.
But if you look at the larger cohort, I do not know. It is still, we do not have enough evidence to say that.
What they have cultured the virus from the placental bed.
They have not found.
There is, it cannot be negated, it cannot be ruled out totally. Even ICMR guidelines say ruled out.
Any of you all have noticed any placental infarcts, microthrombi in the placenta with COVID?
The COVID again leads to higher incidence of preterm deliveries. And fetal growth restriction. So whenever you have this small for age gestational babies or average for age gestational babies, if you send the process of histopathology, invariably you see an element.
Microangiopathy is seen.
What's the present
So sometimes
recommendation?
you can see placental infected areas.
Yes,
You
large
see,
impact.
even you can see it.
So
But
what's
there
the
might-
present recommendation?
No,
Can
we
take,
have not
can the
come
pregnant,
across, but at least it is known that it happens in COVID.
can the pregnant woman take vaccines? What's the present recommendation?
Yes.
Yeah, but
Yes.
most of them are reluctant to take.
You
No,
look at
that
the-
is their issue.
The policy guides are very neutral. They don't say yes, they don't say no. They leave the decision to the mother.
To the mother.
And- But FIGO guidelines are very clear that they are encouraging Moderna and Pfizer's vaccine to the mother. And see, when we are giving ICMR guidelines, our own guidelines say lactating mother, yes, to be taken. But unofficially, even at Fernandez Hospital, our place, we are asking or encouraging the mother to take vaccine after at least 18 to 20 weeks, because the risk of COVID and you look at the ICU admission, COVID non-pregnant, COVID pregnant, ICU admission almost 5 times more compared to COVID non-pregnant patient. And if you look at the respiratory failure incidence, almost 55% versus 9%. I'm talking about requirement of ventilator therapy, 17% versus 2%. COVID pregnant versus COVID non-pregnant, same cohort. So looking at these complications, definitely it is safer to take vaccine rather than avoiding it.
Thank you, Sunil.
Yeah.
So we'll ask for the comments from the senior and other senior faculties in the audience.
Dr. Kameshwar is there.
Morris is there.
Sanchi is there.
Professor and HOD, Government Medical College, Trivandrum. Lynette Madam is there.
Dr. Lynette is there. Madam is there. Lynette Madam and Dr. Shamshad is there. Dr. Mubarak. Professor Mubarak sir is there.
Hello.
Hello.
Yeah.
Hello. Audible?
Yeah, you are audible. Yeah.
Anyway, congratulations, madam. Your talk was excellent. And actually, most of the queries has been covered. So thank you, madam, for your excellent presentation.
Dr. Shamshad.
Madam, it was really good, Indrani madam. It was a really good talk. And we have covered almost all the 4 has covered, I think, almost all the questions. So I don't have any other questions. Okay, congratulations to the whole team for the excellent presentations as well as the excellent discussion.
There is another, Dr. Sunil, there is another question. Any guidelines for anesthetic management of mucormycosis in pregnancy? And 2 questions.
Yeah.
And another thing is that what's the ejection fraction above which you will give spinal?
See, the thing is, coming to mucormycosis, the anesthetic guidelines are same as non-pregnant patient, except that we need to avoid all the medications that are category D and above. And antifungals, liposomal amphotericin B is quite safe because mucor can be a life-threatening disease. But yes, especially if it is rhinocerebral or ocular, then it's an emergency. But honestly, I have not seen mucor in pregnancy so far, at least in our hospital. Children, yes, I have seen. Coming to the second question about the spinal in ejection fraction, again, it all depends on the functional class of the patient. But by and large, if the EF is more than 40%, spinal can be considered safe. But generally, what we follow in our hospital is combined spinal epidural or standalone graded epidural as a technique of choice. Because many a times, ejection fraction, it all depends on the echocardiographer. So many a times nowadays with a busy cardiologist, EF is done by the echocardiographer. They may give sometimes erratic values. So if you trust your cardiologist and says ejection rate is more than 40%, then yes, you can go for spinal. Less than 40, either low dose spinal with CSC as a backup or a graded epidural with, of course, art-line, at least minimum RTL and monitoring.
I agree with Sunil, and I also want to re-emphasize that you must also look at New York Heart Association. You don't have to just see EF. you also have to see what is the NYHS status. of
Clinical
the
condition, yes, absolutely.
Okay, Sunil. Thank you. Thank you so much.
Thank you. Thank you so much. Yeah.
Professor Mubarak
Thank you,
is
Dr.
there.
Venkat Giri
Mubarak,
garu.
sir.
Sir, Kameshwar Rao sir is there. Dr.
Kameshwar sir.
And Muralidhar sir is also there.
Good evening, madam. Dr. Indrani, you've given a nice lecture covering all the aspects. Congratulations, madam.
Yes, sir.
Very nice lecture. You have covered all the aspects, starting from the basics to every part of COVID. You have covered very nicely, and happy to see Dr. Anju Griwal and Madam Sunanda Gupta, Dr. Kajal, Sunil Pandya. Nice interaction. It's an excellent webinar. And the recent times, what I heard. Very nice, man.
Great faculties and doyens of obstetric anesthesia together.
Thank you so much. Thank you
Thank
so
you,
much.
sir. Thank you so much.
Any more comments from any faculties? Anything?
Which one?
Anything we have left? Anything also? Anybody? Anything
No,
we have left?
you covered.
So I don't think.
Very nice. And I should appreciate the Kerala branch for conducting very nice webinars every week.
Yeah, Dr. Venkat Giri and team, ISA Kerala.
It is not fine. Because all your help and support, we could do something and do that. See, we have to do in this time something and for our PGs.
Yes, sir.
ISA. Otherwise, people ask what ISA is doing, what ISA is doing. Yes, ISA is doing something. We should do that.
I especially appreciate Dr. Nazar and Dr. Binil for taking very active interest.
Oh, yes.
Thank you, sir. Thank you, sir.
Absolutely.
Your support is backup for our activities. The support like million people like you.
Thank you for the opportunity.
Thank you for sparing your valuable time, Indrani madam, all other Anju madam, Kajal, then Sunil
Pandya,
Pandya.
sir.
Yeah, thank you very much, and especially Anju madam for telling me that please involve Kajal, and that really had come to my mind. She told Girish, she told that yes, she has a lot of experience.
Thank you, Anju. Thank you.
Thank you,
And
Dr.
lovely to see you all because we want to meet everybody in person, and we are just waiting for these times to tide over. It's been a very long time we haven't seen each other.
Hope we will see in Ahmedabad.
Yes.
Thank you, sir. And we have one more topic topic for today. And Dr. Sajesh ji is ready with his topic. Dr. Rajesh, whether we should continue?
Yeah, if there is no more queries, we'll go to next session. And I thank once again Professor Indrani Madam and the esteemed faculties. And Dr. Vijesh is there. Dr. Vijesh? Hello?
He is there, but he is in the OT.
Okay. We'll go to the next session then.
There is only one aspect which I didn't take up, which is the mental illness, the mental aspect.
Okay, madam.
Anyhow, that has got a little implication in anesthesia, so I didn't take it up.
Okay, madam. So we'll go to the next session. Can we go to the next session? And thank you, madam, and other co-faculties, Dr. Sunil Pandya, Dr. Anju Grewal, Dr. Kajal Jain, and Dr. Anil Satyadas. And we'll go to next session, that is setting up of COVID ICU and OT. We have Dr. Sajesh G, a senior consultant and HOD, Nayar Medicity, Trivandrum. He was past president of ISA Kerala. Dr. Sajesh, over to you. Over to you, Dr. Sajesh. Dr. Sajesh. Hello. Hello.
Sir, he is unmuted. Sir, please share the screen.
Yeah, he's sharing this. Dr. Sajesh, you have to unmute.
Sir, you are not audible. You are not audible.
Dr. Sajesh, you're not audible. Sajesh, you have to unmute.
Sir, now please unmute and try again. You are not audible. We can't hear anything.
Just give a trial audio first. You just talk something, and if we will reply to that.
Hello.
Yeah,
audible. Okay, fine. Okay.
Dr. Sajeesh, welcome.
Okay, fine. Okay, we can start actually. Okay, around 7:43. Okay, fine. And Rajesh, straightforward. Shall we start with the questions straightforward? Because I don't have nothing to say. Anything to say, as Indrani Madam has explained everything, and in OT and all except a few things in the ICU, otherwise everything has done. Anyway, I will quickly go through my topic. Excellent presentation, Indrani Madam, well actually. Okay, we will move on to ICU and OT setting mainly, and a few words on the ICU management itself. And when regarding the OT setting, the operating room settings, I will solely depend upon the ISA guideline, and most of them are, Madam has explained everything, so I can rush through that. We are in a very new normal situation here in COVID. For the last 1.5 years, I am behind this new normal. Everywhere in my life, all of you are in the same boat. But as far as our profession is concerned, I am still with a laptop on a rudimentary, with all the rudimentary evidences. We are very proud of our evidence-based medicine, but the COVID has destroyed everything. Yes, we have absolutely not even a single thing in a COVID which is evidence-based, purely evidence-based. Everything in a rudimentary state. And logic-wise, we apply plenty of logic for all our conclusions. That's why my logic may not be suitable for you. And COVID and me are the same persons, when somewhat living organisms. But I never consider him as a pet. Neither he also consider me as a pet. And regarding the experience gets when we stand alone. That's a term. But I stood alone in the ICU to get some experience, but I failed. Because when I intubate almost everything, more than 80%, 90% is dying. And I will go with the crowd and all of the domiciliary care and everything, all the training and all the COVID management with the public and all. There also I am failing in a great manner. But there somehow we have some consensus on the COVID, and there are only some consensus. Out of that consensus, I am talking about the ICU setting and OT. There are only a few consensus, but everything is a new normal to me. Here, we have a plenty of guidelines. Everywhere we have a plenty of guidelines, actually booming of guidelines and literature and everything. There are more than 10,000 literatures and coming out in every field. And we have plenty of guidelines also. But when I come to the practice, it's nothing is promising. Very few things are promising. And that's a situation, real-time situation, what we are facing. You can argue these. You can argue that what all things I am saying here today is overdoing or underdoing, because everyone has their own new normals, irrespective of the guidelines. So anyway, I will quickly go through the ICU and OT setting up and some aspect regarding the treatment also. Here we have the principle wise, the prepare and implement rapid identification isolation protocols. That's a very, because the institutional base, of course, everything from the WHO, all the state, all the national, national guidelines we have, WHO, CDS, and all of the professional bodies have their guidelines. But each institute we can institute some guidelines on there. Rapid and isolation protocols, then surge in ICU bed capacity. That is very, very key in ICU management, because we can have, when WHO has a very clear guideline and plenty of options for ICU setting up in different setting. Actually, if you have a single ICU or a large ICUs and different things, and very elaborate guidelines has come from the WHO. But the point is that we can expect surge in ICU bed in any time, because that is true, especially in second wave. And even in the first wave, I have been there in Mumbai. There also we have faced this thing, because there is a problem with the surge capacity, increase in the ICU capacity, is that all our quality and your guidelines, everything will be compromised on that point. So that's a acceptable thing. Provide a sustainable workforce with a force on infection control. Actually, as far as possible, you should concentrate on infection control. Actually, ensure adequate supply to equipments in ICU, and especially the PP kits and other protective equipments for the healthcare workers, because here the safety is the primary concern. Our safety is the primary concern. The treatment comes only next. Main quality in clinical management, maintain the quality in clinical management. As far as possible, stick on to the latest guidelines and latest developments, and according to that, you treat the patient. But outcome, no guarantee for it. And of course, an effective communication, because most of the time the issues are the patients are alone in the ICU, and they communicate with the relatives and the interpersonal between the healthcare workers. Also, communication is important. I broadly divide this into space, staff, supplies, and standards. We'll be free with the space, and ideally the negative pressure airborne infection isolation room is the ideal one. That's a negative pressure airborne infection isolation room. Actually, the negative pressure is ideally, it should be -2 to 2.5 kilopascals with 12 air changes per hour. That's the ideal setting. Most of the, preferably it's more than 5 kilopascals, and most of the time the AC fronts of air conditioned unit, they will give us around 4.5 or 5 pascals. The mass critical care, the triaging protocol should be there in ER. Even sometimes we can expect a huge number there, actually, especially in containment zones and all. Suddenly the number will increase. So you should have a proper triaging protocol. That is the main aspect of COVID management, because definitely you will designate some area of in the hospital as a COVID area, and some area you should protect as a non-COVID area. But the problem is that if the sudden mass casualty wise and the sudden surge of patients can spoil everything. So you should be very keen on that, the triage at the ER. That's the key. Rapid identification, isolation of suspected and non-COVID cases, that easily you should identify, and rapidly you should do actually all the tests and other clinical examinations or radiological examination, whatever may be. Ensure access to rapid diagnostic tests like laboratory facilities like immediate antigen testing and RT-PCR and other things. RT-PCR should take a minimum of, if you don't have a laboratory facility inside, that means the RT-PCR facility is not there. You should have a good license with the laboratory nearby to get reports as quickly as possible. And initiate planning for surge ICU bed capacity we discussed. Utilize a normal pressure ICU. Most of the ICUs in a hospital, you should have a plan prior to this thing, COVID, embarking in a COVID and taking COVID patients actually, which are all the ICUs we are going to convert to COVID ICUs and which are all the ICUs you are going to retain as a non-COVID area. That is very important. That area-wise also, and especially the building wise, or at least in the floor wise, you have to segregate that COVID and non-COVID area. We can utilize the OT in emergency, then of course post anesthesia care and ST unit, endoscopy suite, and all of the things. You should have a clear plan to say differentiate between the non-COVID and COVID ICUs. Alternate, you can have a cohort bed with the physical barriers, because a large area you can convert into an ICU and all. The only thing is that the negative pressure setting up all thing will be a little difficult, but still you can do with very powerful exhaust and all. Ensure timely step down of stable patients with the de-isolation protocol. That's very important. As early as possible, you should de-escalate the patient, shift the patient, but it is very difficult in a COVID situation. We know that lung needs time to cure. It takes at least a few weeks to settle down. Staff and the staff's segregation into the frontline team and implement strict infection prevention and control measures and training. That is very, very key in that staff, because I myself for the last only at around April, in the end of the April only, I am using the full coverall PP kit in my lifetime. Because then we heard about this PP kit in Ebola and all of the things, but we never tried it on personal experience where I didn't do actually. So even we are not familiar with this thing. So the situation with other supportive staff members like staff nurses, our PCAs, our cleaners, everyone has to have it. The training is very key actually here. Staff surveillance, actually, we should also monitor the staff, the health conditions. Okay, we had good surveillance and the frequent checkup and all. Ensure a dissemination of timely factual information to establish two-way communication. What are the latest things you should have to communicate with our staff members. Provide helpline for the and psychological support. That's very important. Actually, when we landed in Mumbai and with an ICU in Seven Hills Hospital, and we started functioning in the ICU, we had around 40 doctors from Kerala and around 60 staff members from, staff nurses are there, and even our juniors, registrars, they were asking the very first day onwards, we are every day in our ICU, 3-4 deaths are happening. They were saying yes, that, sir, why we came here? We came here to just certify the death, and that kind of a depression we can have actually, especially that has happened to with even doctors and with staff nurses and even all other healthcare providers. So the lifting up their psychological level and their morale is very important actually. Hands-on training and refresher courses is very important. Minimize unnecessary procedures and transport. Increase manpower capacity by actually we can deploy more from the other departments actually. Even the doctors in most of the medical colleges, even forensic medicine, all of the non-clinical departments are supporting us in the clinical field. And of course, the staff members also. Those who are in the trained ICU staff nurses are there. That's the most demanding people there in ICU. Of course, we can the intensivists, but the trained ICU trained staff nurses. That is a luxury in a pandemic actually. So those who are there in our institute, or you can appoint actually new persons. That is very useful, and it's a luxury there. Of course, we have to compromise on patient healthcare workers, especially staff nurse ratio actually. And supplies, actually they ensure adequate supply and stockpile the PPE. That is very, very essential, because the stock will exhaust within, in a days actually we may be in short of PPE kits and everything. And so you should make sure and you should ensure the adequate PPE and other consumables, even medications actually. And as far as possible, use single-use things, equipments also, you should have segregate the equipments, especially the ultrasound machines and other dialysis machines are dedicated for the ICUs prior to starting up the ICU, because once ICU started up and everyone is with PP kit in full coverall and all, it's very difficult to install new machines there. It's prior to that you should especially X-ray machines, ultrasound, dialysis machines and everything. Ensure adequate cleaning services, that's very essential. That's especially the staff nurse, staff, cleaning staff and all, regularly we have to have at least 2 to 4 hours. You should clean the ICU premises. And extended use of N95, because we may run in shortage and we may have to use it. And this is an as I said, we can say it's an ideal ICU, but in the real-time situations, that's not possible. Here we have a U-shaped one. Here on each side we have separate cubicles separated by the common corridor by the glass doors, and only one patient is admitted there in that each cubicle. And the corridor, we can have a positive pressure there in the corridor, and the cubicles we can easily provide negative pressure there. Actually, the pendant, for the oxygen suction and everything, you have pendants, so that you can clean the surfaces frequently and very effectively. We can clean the surfaces. That is actually, this is an ideal setting, but this is only for the concept wise. And normally we may not get this kind of a nice setup in every hospital, especially in actually surge of ICU beds is required actually. So this is attached with the bathroom and everything is there. But the key position as far as this ICU is concerned, the negative pressure actually. We will come to that, and that is the negative pressure. That is the key for the air. We know that most of our procedures are the aerosol generating procedures. So we need a negative pressure ICU setting. This is a negative pressure. This is the main ICU. AC throw there, it comes from there, and actually on the opposite side, and that's especially in the head end of the patient, we have another exit. You can see that there is the exit. This is a exit portion, and here the air from that throw comes from the opposite side, and it is sucked out from the exit. Actually, we have a 2.5 pascals. Actually, and around 12 air cycles per hour. This is we are going to start a new block. Actually, this is a negative pressure testing with fumes. You can. This is the corridor area, and in that area we can keep that positive pressure, so that that viral particles won't come from inside the cubicle to the normal corridor areas. And the advantage of this is that definitely is in the negative pressure area, the efficiency of AC, that's cooling efficiency, will be less. And with the full coverall PP, it's very difficult to stay for 6 hours on that ICU. And in a normal area that is in the corridor, we can keep it positive. And most of the time we can stay there only for some the procedures and the examination and everything. You can come to that, you can go to the patient cubicle. Otherwise, you can stay on the corridor. And what I personally do is that I just walk over this thing, the corridors, and we can find out many things. One day I found out that just a tube was just disconnected, breathing circuit was disconnected. That is actually, this is a throw comes out from here, and opposite side, this is the exhaust, and it is vented out actually. You can see that it is sucking in, the fumes are sucked out. And that is an ideal negative pressure setting. Okay, leave it that. Then the infection prevention control aspect, mainly the 3 areas we should concentrate. That's the healthcare workers, infection control at the for the healthcare workers, the patient, and an environment. Healthcare workers, as I said, the safety first, everything comes next. So our safety is the important thing, and our PPE, proper donning and doffing is the key. And regarding the patient, of course, this is the patient, as far as the patient is concerned, the infection control as far as the patient is concerned is get out of this bloody bug. So more than that, a secondary bacterial infection, if you're there in the PAP and all of them, the patient stays long for the ICU. Environmental, of course, we have discussed this is negative pressure and all. There is the infection control protocol in elaborated one, as since in a postgraduate update program, I'm just putting it because I'm not going into the details of each one. It's there in the almost all guidelines, and especially the patients, the droplet and surgical PPE, the surgical mask and eye protection, disposable gown, gloves, and cap. Caps should be there, and N95 is a must in ICU, and airborne precautions has to be established there. Aerosol generator procedures, repeatedly we will discussing everything. That's why I'm skipping all these slides. And especially in the ICU, we should have a bag wall mask interface. That's a bacterial HMEF filters. That's a viral filters. You should keep it in. Whether we are using NIV, intubated patients, or any other device you are using, it should be there. And as far as even with the mask, nasal prongs and all, you can put the surgical mask over the nasal prongs, or a mask, put a surgical mask, that's Hudson mask, over the surgical mask. Then intubation, we will discuss it later, but intubation also is an aerosol generating procedure, and here the key is that the PP should be adequate. PP should be there, and the breathing devices, bag, valve mask devices, breathing circuit, everything should be ready, and proper pre-oxygenation. Of course, we know the rapid sequencing induction what we are using, and we don't conform. Madam is elaborately, Madam explained everything that we don't conform with the stethoscope. Actually, with the ETCO2 we can conform. And regarding the survival sepsis campaign, the latest guideline has come out with an elaborate one. It's recommendations. I'm taking only the strong recommendations or basic requirements, basic practices only. Even the prone ventilation, everything is a good recommendation. Good consensus are there for the survival sepsis campaign in relation to the COVID as come 2020 there. Infection control, as far as infection control is there, and AGP, that is aerosol generating procedure, PP kit, and N95 is a must. That's a strong recommendation. AGP should be done in a negative pressure room, either in a negative pressure room or in a negative pressure ICU. If intubation has to be done in a common area, then it has to be brought into the negative pressure room actually. Endotracheal intubation is performed with the most experienced person. That also is a strong recommendation. Hemodynamics, it's not to use dopamine over noradrenaline. That's the first trial of drug is noradrenaline, even in COVID. Ventilation, the supplemental oxygen, we should not aim for SpO2 more. The supplemental oxygen can be given if SpO2 is 90, and in acute hypoxic respiratory failure and oxygen, we should not aim for more than 96. And close monitoring of NIV, HFNC, and early intubation. Early intubation should not delay intubation with NIV and HFNC. We will discuss it later. And low tidal volume, everyone agrees on that. Low tidal volume 4 to 8 ml per kg, and plateau pressure, that's very key in COVID management. It should be less than 30 centimeters of water. And moderate severe COVID ARDS use high PEEP strategies, and they are against the staircase, that's incremental PEEP if you are using any recruitment practice. Therapy wise, a lot of drugs are inefficient. from the sepsis survival team's recommendation. In ICU admission, we know that everything is that we have plenty of guidelines, as I said earlier. ICU admission criteria, we know the criteria. So I'm not going into the details of all of things. But what is the ARDS? In a normal ARDS, I will just move on to the ventilation part and the treatment part of ICU with ARDS. We know that the normal ARDS definition we should know, especially the postgraduates are there, you should know that normal ARDS, the onset is a new or worsening respiratory symptoms within 1 week of non-clinical insult actually. And chest imaging, radiograph, CT, lung ultrasound, bilateral opacity is not fully explained. Effusions, lobar lung collapse or nodules actually. And origin of edema, respiratory failure, not fully explained by cardiac failure or fluid overload. And it should be done by echo assessment. And oxygenation wise, we have mild, moderate, and severe. PO to FiO2 ratio is the key in differentiating these three. Is less than 300 and up to 200 with a PEEP or CPAP of 5, and we call it as mild one. And another criteria, if PO2 is not there, we can use SPO2 FiO2 ratio that should be less than 350. Moderate is PO2 FiO2 is 200 to 100, and severe is less than 100. That is a classical ARDS picture. And what happens in the COVID actually? COVID, we know that it's a 3-week or minimum 3-week journey actually is in the COVID. We can divide it into first week, second week, and third week. In the first week, the first phase, that's an early infection phase. Here is a viral replication phase. Actually, virus replicated around 7 days or 8 days, and within a 10-day maximum of 10 days, maximum replication occurs, and it's gradually come down. And after 10 days, in most of the time, the virus won't be there in our circulation. That's why we keep around 17 days. That means after 17 days, 99% of the persons are not infected. So that's the viral phase. And the second week, actually, phase 2 is the pulmonary phase. Actually, here it's an interaction between the viral phase, virus, and the host immune response. Actually, each initial phase of this thing, virus is predominating, and then the later phase, the host immune response is predominated. Because the problem with the host immune response, we know that it's our innate response immune mechanism is not efficient here in this one, and its immune mechanism is the new coronavirus is unfamiliar to our immune mechanisms, so the immune mechanism was turned in front of this pretty bug. And so what happens is that this produces a increase or exaggerated immune response, that we call it as a dysregulated immune response. That is what in a normal term we call it as cytokine storm or something. That happens in the end of the second week and the beginning of the third week. And that time, by the time the patient might have had all the initial damages, virus has been entered in the lung and invaded into epithelial cells, endothelial cells, and all, of course, and microthrombi has been established, viral pneumonia has been established, but it can produce from mild to moderate there. But in the second weekend all, because of this dysregulated immune response, we can have a cytokine storm. Okay, this can be another second major fatal situation. The management of all things, we know that still a lot of controversies there, but this is the understanding at present we have. You know, the mild one, mild, moderate, and all of course, in an ICU critical care, we are we are facing this moderate or severe COVID patients. Here, the classic, the simple terms, it's a respiratory rate more than 30 and SpO2 less than 90. The investigations, what investigation we do, all the regular routine investigations, our blood counts and general examinations, of course, then the laboratory wise, all the blood counts and other specific inflammatory markers we do in lactate, CRP, C-reactive protein, procalcitonin is there isn't any secondary bacterial infection. Of course, the coagulation profile is very key, as it's mainly a thrombotic condition there. So then we have a ferritin, LDH, and all of the things. Of course, it can affect wherever there is blood vessels. It can affect all organs wherever there is blood vessels. So it can mean prominently, other than the lung, it can affect the heart, kidney, liver, brain, everywhere. So we have cardiac imaging also we should do. This is Gattioni's principle. Gattioni's original slide actually is his original slide, and this is a concept he developed. The Italian intensivist he developed as and for the oxygen therapy and support. Here, the initial hypoxemia he divided into L phenotype and H phenotype. Actually, this concept is fading out actually, but still it's relevant. That's why I'm just pushing. A lot of people are putting some choreo on this concept, because the problem is that in real practical sense, we get a mixed picture. We don't get a clear L phenotype or H phenotype. That's the situation what we face in real practically what we are facing actually. Anyway, the hypoxemia initial phase, we have a dysregulation of pulmonary perfusion. We know that it's a pulmonary microthrombi, and this is more of a dead space ventilation in our ventilation point of view. It's more of a dead space ventilation than our classical ARDS picture of shunt fraction. Actually, here the problem is that there is low elastance. That's a good compliance is good. Ventilation perfusion mismatch is less. So here the recruitability also is less. So we need a lesser people also. That is there in the initial L phenotype. And then the other side of this thing, pulmonary ARDS, there is a pulmonary collapse and everything. There is a H phenotype. There's a lung is elastance is high, lung elastance, then means lung compliance is low, and recruitability is high. Lung is actually wet, actually weight wise, and it's a wet lung. Actually, this is a classical ARDS picture. But we get a patient in an ICU with the COVID patient starting from this initial phenotype of L phenotype to when established ARDS, but most of the time is in a mixed picture. So that we explain that. Anyway, the oxygen therapy and the respiratory support is mainly depending upon PaO2 FiO2 ratio. We know that it's around 200 to 300. Some mild cases, mild here. We can have a nasal, we can try with nasal cannula, oxygen mask of NRBM, high flow nasal cannula, HFNC. PaO2 FiO2 is between the moderate cases. We can still have with HFNC, but the problem with HFNC in the second wave is that what we face is that we almost gave up the HFNC because of its high oxygen consumption. So most of the places, almost everywhere in the entire our country has faced a huge oxygen shortage, and so we are not able to produce, the good effect out of the HFNC in the second wave. Non-invasive is still a key thing, and most of the centers, I'm sure that most of our friends will agree that around 80% of the IC load we do, in ventilatory load we do with the non-invasive ventilation, of course. And of course, is still you say PaO2 FiO2 is not maintaining. The invasive, you should go with the invasive mechanical ventilation, but the point is that it's not the early intubation. It should not delay the intubation. Actually, you can have a try of non-invasive or HFNC, but don't waste time on that if it's not productive or it's coming out. And of course, in a severe hypoxemia or refractory hypoxemia, last option is ECMO. That's only for a theoretical one. Theoretical in the sense, only for a selected patients and selected centers, we get an option of ECMO. And most of the time, we are simply ventilating this fibrotic stiff lung, and for months, and the last actually 2 weeks and 2 days back, one of our patient, we had ventilated that guy for around six weeks actually, and 2 days back he left us. Very stiff. I mean, this thing, HRCT score of around 24, 25 actually. And anyway, whether in cannula or high flow nasal cannula or an NIV, and we should be frequently, we should reassess actually. This is just go through the quick flow chart actually. COVID-19 with hypoxia is indication for endotracheal intubation or not. Yes, then yes, that means you severe hypoxemia is there. You can do with the endotracheal intubation. Expert should be do the endotracheal intubation. All other personal protection equipment should be there. Minimize the staff number there, and of course the video laryngoscopy is preferred. And repeatedly we are telling all these things. But this thing, indication for no tolerating supplemental oxygen. It's no indication for the endotracheal intubation. Then tolerating supplemental oxygen, then okay, it's monitor, close monitor. Target should be more than 93. And but the point is that if whenever you should not delay on intubation and mechanical ventilation there. Of course, we can have a trial on HFNC, so he is not tolerating with oxygen, then of course with the NIV. But the NIV and HFNC, again and again, I'm telling you that should not delay intubation. But the point is not a straightforward take actually on this thing, because if intubate means intubation when it's in a good, not in a good center, a good intensivist is not there, good supporting staff is there. Most of the time, the real practical issues that if you intubate, most of them will die off because of the lack of care. Actually, we know that basic care in any mechanical ventilation patient, the basic care is attributed to around 95% of the outcome. 5%, only 5% is, because of our expertise in ventilation management. In the mild case, of course, we can have a 4 to 8 ml per kg, and plateau pressure should be less than 30. And investigate for the bacterial infection. If there is infection, we can have an antibiotic, but there is some, even in intubated patients, even some given prophylactic empiric antibiotic, but in most of the guidelines is not recommending it. And target SpO2 should be 92 to 96 only. You should not aim for the higher SpO2 levels. And of course, the fluid, of course, we know that the conservative fluid therapy and systemic steroids. In moderate cases, consider PEEP and neuromuscular blocking agents for facilitating for the better ventilatory targets actually, especially the your concept of proning and all, we need a neuromuscular blockade and good sedation. And traditional recruitment maneuvers, if the lung is very wet and stiff, the prone ventilation for 12 to 16 hours, and do not recommend staircase, that is incremental recruitment maneuvers. And adjuvant therapy wise, antiviral chloroquine we'll discuss later, and consider prone position everything. Okay, and consider ECMO is very thing. Treatment wise, general principles, antiviral and oxygen therapy. I will quickly go through the treatment also. HFNC, NIV, CPAP, O2 intubator. That's I'm in strict. I'm not going to the details of each one because it's a ventilatory management, which is a big topic. We can start with NRBM, HFNC, or NIV. But the point is that only one point I'm going to mention here in this regard is the self-inflicting lung injury. SILA is the hypoxia can induce a vigorous inspiratory effort, and that vigorous inspiratory effort can lead to self-inflicted lung injury and increased interstitial edema. The baby lung concept of ARDS is that some areas, the majority is around 30% in the initial phase, of the lung may be a good lung, that is a baby lung, then may have some collapsed lungs are there, then okay, full wet lung, different, actually is in a mixed picture in classical ARDS. So again, the baby lung, which is normal there, can again leads to hypoxia. That's a vicious cycle there. You know, vigorous, even patient is training, that's a clear indication is that vacuum breathing. If there is an increased vacuum breathing, that's a clear indicator of this developing SILE. We have seen plenty of patients with spontaneous subcutaneous emphysema, spontaneous pneumothorax, and all mechanical ventilation. Again, I'm not. It's actually it's very essential, but I will quickly go through that. Ideally, should be done in a negative pressure. Airborne precautions should be taken. Limited number of persons should be there. Video laryngoscope is the preferred one, and pre-oxygenate. And actually, we have to clamp the endotracheal tube while intubating, or you can connect the filter, even filter prior to that. And of course, close suctioning. That is a very key. It's very essential in a COVID scenario. That's a closed suctioning system that avoids the AGP procedure. AGP, that's aerosol generating procedures, can be reduced. So viral load can be reduced. More than that, we can prevent, because it's a long journey. Once you are intubated, the patient will stay around at least for 10 days to 14 days will be there, and we can expect VAP and all in the next week itself. So you can prevent the VAP by the endotracheal and closed suctioning and all. And mechanical ventilation, we said that the strategies we have discussed, and pharmacotherapy. And pharmacotherapy, actually, current day evidence states only 3 things are working there: only oxygen, steroid, and anticoagulants. Even though it's not a pharmacotherapy, it has got a promising thing. That's why I put its proning as a life-saving one. All other things is evidence-based. As the current, as I said, again, the evidence is we don't get a good statistical studies. All the studies have some issues there, and we don't have a huge data there. And so many issues that we don't have RCTs. So many issues are there, but still the current day understanding is that these are the 3 things works mainly. That's a life-saving things. All other things are up to your discretions. Remdesivir can be used, especially in comorbid conditions. That the only thing is that you have to use in the early phase. All of the things. Okay. Anyway, the ivermectin, SCG, lopinavir, ritonavir, all of the azithromycin, doxy, everything has gone. But I cannot say it's straightforward, because most of our national and state guidelines, it's there, still there actually. Again, the treatment-wise, the remdesivir, actually 200 milligram IV, the start day, and 100 milligram for the 5 days should be given early in a comorbid cases. Another key agent is a thrombo anticoagulant. Actually, here the mechanism action is very interesting. That's one of the key mechanism of action of COVID pneumonia, not only pneumonia, and all other organs accessible. And it produces an cytokine storm, and inflammatory systemic SIRS can be produced, and ultimately can have a hypercoagulable state and endotheliopathy. And again, that will cause hypoxia. And in the it can have either microthrombosis and multi-organ failure and microangiopathy, and leads to ARDS, and the macrothrombosis, that is a venous and arterial thromboembolic, this thing. It's mainly a platelet fibrin thrombus. Actually, it's the peculiarity of this thrombus is a platelet fibrin thrombus. That's why some say that aspirin also is useful in the treatment. Anyway, wherever there is a blood vessel, it affects there. There's a pulmonary vascular thrombosis. That's why we discussed that L phenotype, at least in the early phase, is dysregulated pulmonary circulation is there. Actually, that bypasses or negates, abolishes the hypoxic pulmonary vasoconstriction. So that is an English blood flow through that affected area. That is a basic pathology there in the initial phase. That's a L phenotype. And so that's why we have to, if you want to use an anticoagulant, we have to use it at the early. Whenever, as soon as the hypoxia set in, we have to use it. So if once the hypoxia is set in, two things you have to give, actually it's steroids and anticoagulants. Of course, anticoagulant, we have to we have to weigh the merits and demerits, mainly done by the early D-dimer estimation. If D-dimer is more than, so many guidelines, different centers have different guidelines, but so common consensus is that D-dimer is more than 0.5 and more than 1, then we start. Anyway, this is on guideline. This is actually is from our state Kerala guideline. Actually, here the moderate to severe ARDS in the high risk thromboembolism there, then admit in ICU unit, and we can give a heparin, parenteral heparin, or you can creatinine clearance is more than 30. You can have an enoxaparin 1 milligram per kg BD. Creatinine clearance is less than 30 ml per minute. Then we should use actually unfractionated heparin. It's a bolus bolus dose of around 80 units per kg, and then an infusion of 18 units per hour if in a normal persons, and 15 units if high overweight patients. So anyway, 80 and 18. That's a heparin dose for this thing. If the D-dimer is very high or risk of thromboembolism. So low risk thromboembolism, the D-dimer is high, again the same thing. D-dimer is more than 0.5 or between 0.5 and 0.3, we can use enoxaparin 40 milligram OD, and in an obese patient we have to give 40 milligram BD. If you're an unfractionated heparins, 500 units, you can give a BD, and 7,500 in obese patients. And D-dimer is very high, we give a bolus creatinine clearance of less than 5, bolus of around 8 units per kg per hour, the unfractionated heparin. So the 80, 18, and 8, that's a normal mnemonics what we use. Then the methylprednisolone and the remdesivir are actually I'm not concentrating on the remdesivir portion. And in the MI, when we were there in Mumbai, actually, this is we thought it is a very promising thing. Tocilizumab and remdesivir may be the very promising things, but now the current evidence is not supporting. It's not a mortality wise, it's not that much benefits, but still, cytokine storm or really is there is a hyper-inflammatory state. Is that we have to use tocilizumab. If you are using it, it's an 8 milligram per kg of maximum of 800 milligram. May repeat after 12 hours depending upon the condition. Of course, plasma nowadays it's actually no one is using it. Supportive care, we have mentioned almost all things, and HEPA and PP is. Okay, we have discussed everything. Finally, on a patient, on a hemodynamic instability, and we should assess the work of breathing. And work of breathing is very high actually. Then you can try with the non-invasive ventilation or invasive ventilation. Very high work of breathing is very high, and all of the criteria is that very high severe hypoxemia, you can directly invasive ventilation, or we can give a non-invasive trial, and according to that we can manage. If invasive ventilation, of course, H and L phenotypes. Yeah. I'm rushing on these topics. Okay. And when you are intubating and ventilating, your goals or your strategy should be a lung protective ventilation with the plateau pressure of less than 30 centimeters of water and a driving pressure of less than 15 centimeters. and you can adjust accordingly. If there is a plateau pressure is high, then you can reduce the tidal volume by 1 ml per kg, or a plateau pressure is less, then we can increase actually. Then pH, we have to maintain a normal pH around 7.3 to 7.45. If there is a pH is very low, we can increase the respiratory rate to maximum of 35 per minute, or we can give a trial of soda bicarb. Oxygenation, of course, we know that PO2 and SPO2 has to be maintained. Of course, PEEP, we have to use PEEP according to the PEEP FiO2 chart. But if it is refractory hypoxemia, that is a very common actually in most of the intubated patients. We have nothing to offer, but we are facing this problem of refractory hypoxemia. One thing we can try is the prone ventilation. Prone ventilation has got is a promising thing. It has to be given 12 hours per day, 3 to 4 hours in each session, to a maximum of 3 sessions in a day. Actually, the mechanism also that we know that in a supine position, the distribution of the alveoli is maximum because of the shape of the lung. The more alveoli in the basal portion, that's the dorsal portion of the lung. So more pressure there and the fluid collection there. So less alveoli is available in the ventral portion. And again, the problem is that perfusion is high on the whether you are in a prone or a supine position, perfusion is normal or maintained, but for they have a low, high VQ mismatch. That means perfusion is very high and ventilation is not adequate there. If you prone, what happens is that the more alveoli are in the is on top, and less alveoli are there in the bottom portion. So more alveoli is available. And another advantage is that the abdomen, because of the shape or attachment of the diaphragm, the abdominal content pressing on the supine position is more pressing, and everything will be with supine position. The pressure effect is more with supine position than on the prone position. So theoretically and technically, prone has got a better things, but it has got its own issues because patient is very hypoxic. It's easy to say that you prone the patient, but in a practical sense, it's very, very difficult actually, because you should have at least 3-4 people out there. The prone team should be at least 4 to 5 people will be there. Then the endotracheal tube and airway access is a big issue. We can have an accidental extubation. Then IV lines, central line, everything have to be protected. And every time the point is that the consultant is very difficult to stay with these patients, and that ICU team has to do it. So in the practical sense, it's very, very difficult things, but it sounds useful and it is promising. High PEEP, of course, we need a high PEEP. Recruitment we are discussed. Is not recommended. Incremental recruitment is not recommended. ECMO is a good one, but the only thing is that you should not wait the patient to exhaust completely, because if you want to put an ECMO actually, you have to do it early in the sense initial phase of refractory hypoxemia. You have to do it early. If your early ECMO has got a promising effect actually. Plenty of patients are coming out with the ECMO, but ECMO, the problem is with ECMO is the main thing is the availability of ECMO, and the second thing is but the most important thing is the cost actually. And if you put on ECMO, at least we have to maintain them for 10 days, or most of them will be there 10 to 14 days will be there, taken there. Another supportive care, fast hug, BID. That's everything is there, and it's there in all of the guidelines. Nothing to say about that. Your feeding is very, very essential, because as early as possible you should start feeding. Enteral is the ideal one. It's a continuous feeding bag, enteral bag. It's a continuous infusion. We can give it formula feeds. Then analgesia, of course, that is very key. And sedation. Especially the patient, we want to maintain on, especially on prone ventilation and all, good sedation and the muscle relaxation is essential. Then prophylaxis, as COVID itself is a hypercoagulable thrombotic situation. Not only in any other patient, even otherwise COVID in any ICU patient, we have to keep a watch on thromboprophylaxis. It's a key thing. Head and elevation, also prophylaxis, glycemic control. Another very big important area is the glycemic control. Especially the point is that the most of them are the comorbid conditions. So most of them have a diabetic or uncontrolled diabetes. These are the patients who are going to get worsen actually in the ICU. And with the comorbid, especially obesity, diabetes, hypertension, and all things. So the glycemic control, even otherwise, it will be uncontrolled diabetes, and ICU, we have to get a good control there. Another thing is that with steroid therapy, because we are giving a steroid therapy can increase distort the glycemic control there. Anyway, you have to maintain a glycemic control of around 140 to 180 milligram per deciliter. Spontaneous breathing trial is all our aim is to extubate as early as possible. Then the bowel movements, indwelling catheters, and de-escalation of antibiotic. That is very key actually. That's hit hard and de-escalate as early as possible. That's the role of intensive care. And weaning criteria, I'm not going to the details of this one. Just mention it as a criteria there. The basic thing is that primary pathology has to be clear. But how far it is possible in COVID, that means we can't get complete clearance of the primary pathology because lung need more time actually. So we can extubate the patient, wean the patient, extubate, and we can have a NAV trial on that. And PO2, FiO2 should be more than 200, then PCO2 more than 60, and FiO2 less than 0.4, the SpO2 of course more than 90, and the protective airway reflexes. And anyway, the main ventilatory strategy we can have actually permissive hypoxia and permissive hypercapnia. We can have a hypoxia and hypercapnia allowable to a great extent. Then RSBI ratio is less than 105. That is a rapid shallow breathing index. That means around 80% success rate on extubation. Criteria to transfer ICU from ICU, of course, the stable patient. And last, and we'll take quickly, I will go through, and almost 50 minutes is over, and through the setting up of COVID operating room. This is entirely on the ISA guideline, and most of the things that Indrani Madam has done and elaborately discussed everything, but I will just mention the headings of it. Name of the operation theater, we have a dedicated theater. It is a COVID-19 operation theater. That's we have to have it dedicated. Ideally, we should have two COVID OTs, one for the dedicated, one for the obstetric purpose. That is a emergency, most essential emergency that we can't deny actually. So we should have a dedicated obstetrics OT and one OT for all other purposes. Location, it should be an exclusive on a dedicated block or in a different center altogether. Should not have any adjoining inhabitant buildings within 20 meters, preferably located close to the COVID ICU, HD, and other important areas. If you are immediately, we want to ship the patient in a COVID ICU, dedicated COVID ICU, it should be very close because the transportation all will be, the area of transportation should be minimal. There is chance of contamination and transmission is there. So the area should be minimal. Another thing is that as early as possible, you should ship the patient to the ICU. Changing room, of course, we have a separating changing room, donning and doffing. Adequate PP kit with all the coverall is recommended, ISA recommended. But again, the point is that donning in the ICU, I don't know how far or how many of you are using the full coverall PP in ICU. But nowadays the concept has came down to surgical gown, not the full coverall. Of course, you should have a proper N95 gloves, face shield, and cap and everything. But the full coverall, most of them are not using, and most of them are not recommending in the ICU. But in OT, ISA is still holding on with the full coverall PP. Doffing is very important because doffing area is very difficult to keep a doffing area separate. As in the ICU, that's very easy because setting up an ICU, we can have a separate area. We can have a designated donning area and doffing area because it's a permanent or a regular process actually. But the OT, it's normally what I've seen is that most of the time the doffing area, we don't get a definite doffing area in OT. That is a big issue, but you should have a doffing area there. And separate entry and exit. Of course, the patient, when the patient is shifted, patient should not be come to the main area or pre-op area and all. Airborne infection isolation requirements have to be met. And independent regarding the AC, the independent AHU with the HEPA filters. If the laminar flow OT are used or centralized oxygen, centralized AC units are used, then it's very difficult to have a OT, separate OT on that actually. If you, ideally you should have a separate AHU for the COVID dedicated COVID OT with HEPA filters. Make a negative pressure, again the same thing, minus 2.5 pascals, preferably more than 5 pascals. The minimum of 12 air changes per hour. Incoming and exhaust air should be treated to avoid contamination of the viral particles, and it should be treated and you should just discard it. Or the easiest way, and the most of the OTs now functioning in a other way, because the separate AHU and HEPA for the dedicated OT can afford only in a corporate setup and bigger settings. In a smaller settings, what we can do is, the most practical thing is, we can have a 2 split AC conditions in a regular OT with the 2 ton of capacity, and you have 2 exhaust fans. Now, of course, we should have an inlet, air inlet, and exhaust should be separate one. Air should become on one side and then exhaust should be on the other side. But the point is that, again, the exhaust air should be treated and left actually. And ideally, it should be treated through AHU or HEPA filter, or you can have a chemical disinfection with 1% hypochlorite, and the exhaust air shall be let off into the atmosphere through an upward plumb of height of 3 meters above the tallest point of the building. Or UV radiation. WHO has got a clear-cut guideline for the UV radiation. That means a separate, duct for that, with connected with UV lights, and the exhaust is passed through the duct with the UV lights, and you can treat there, keep it there for 15 minutes, and then left at air. Or heating, just simple heating. These are anyway, the most practical and useful thing is a split AC with the 2 split AC with the exhaust fan. But here the problem is that the efficiency of the air condition will be temperature will be around 24 to 30 degree. And another point is that infection point of view, we are compromising on that infection control. Surgical site infection. Remove all non-essential equipments. Actually, if you have a pendant and all thing, it should be there. And transparent plastic sheet cover, that's very important. Especially your anesthesia machine, operating cautery and all of the anesthesia machines, you should be, especially, this is the most useful thing that what I feel is that you should cover the anesthesia machine with a complete plastic cover. And disposable equipments as far as possible, especially the spinal kit and all. Now we get a disposable kit. Entire thing you use in a disposable kit, we will get that, including the syringes and everything is there, and you can use, and you can discard it easily actually. Heat and moist exchanger, HMEF, actually HMEF filters is a viral filter, is an actually in a good quality viral filter. I'm not sure what we are getting is how far it is good, and because they are cheap, around 100 rupees or 200 rupees and all. How far it is efficient, I don't know, but actually ideal one, little costly. Normal viral filters around 400-500 rupees. Still, the HMEF filters at the expiratory limb and at the tube end is an essential. Scavenging, active scavenging is the ideal one. At least you should the outer part of anesthesia machine, the exhaust air, put a corrugated tube and dip in a 1% hypochlorite solution. And aerosol generating procedures, of course, you should be careful. Number of persons should be less, and PP kit, of course, the full coverall is a recommended one. Communications is an issue with all the PP and all. You should have a alternative way for that. Oxygen supply, that is very, very essential. Actually, we should be, especially in the shortage of oxygen cylinders and other central oxygen supply. Because with all of the COVID things, you don't get much support from outside. So especially the oxygen cylinder is over in the midway of the surgery, then it will be difficult. So the supply you should ensure. Another thing is that the on refilling the when you are giving the refill cylinders, then it has to be sterilized thoroughly. Sterilization, contamination, madam has said very clearly, madam mentioned. I am just skip all these things, the paucity of time. Anyway, we can use 1% sodium hypochlorite or 75% alcohol is the key in all of this thing, cleaning and purpose. And so as far as possible, use disposable things. And wheeling the patient in only after all are ready, because it should be everyone should be in full PP and everything. Then only you should bring the patient in directly to OT and not through the regular route of this thing, your pre-medication room and all. And we are gown and mask, and wheeling out of the patient, you whenever possible, extubate the patient and keep the OT for a full recovery. At least if you just extubate and you don't just extubate and send the patient, it's not an ideal thing, because in the post-op, it's not a regular post-operative ward or post-anesthesia care unit or ICU where we can directly enter. So full recovery, you should ensure the full recovery. Accompanying persons should be with PP, actually with the separate PP actually, and dedicated lobby and elevator should be there, and training is the very key. And whenever possible, the regional anesthesia you should give. Again, the GA, I'm skipping that and I'm stopping it almost 1 hour. So ICU, in setting up of an ICU and OT for a COVID patient, the first and most important thing is the safety of the healthcare workers. Our safety is the first, and everything comes next. And in the management of the COVID, we don't have a single magic bullet, but we have a lot of promising medicines, techniques, and more than that, in a critical management, 95% of the outcome depends upon our basic care and nursing and all. So we have many things to offer here in COVID situation, and with the comprehensive critical care, it's not that much deadly. Even though we are getting a very young patients are dying with very stiff lung and all, but you take the proportion is very, very less actually. It's a long walk, as lung need time to cure. That means lung need time to cure. If you on a NIV, that means at least 7 to 10 days, 7 days, we may be there under 10 days. If you just intubate and ventilate the patient start, you should plan it for at least 2 weeks and may extend to 3 weeks or 4 weeks. So it's a long journey, plan accordingly. So when transferring out from the ICU is not that easy actually. So anyway, with all of the precautions, we will do better. And most of the country, most of our part of our country, as second wave came down, and we are in a little still in the ICU is not relaxed in all over the India. All our ICUs are busy, but the overall number has came down, and we can expect the third wave also. So we should be prepared. By the time of the third wave, we hope we will get a better critical care management strategies, or even good medicines. For the time being, the social prevention by mask, SMS, and other avoiding the 3 C's, and of course, vaccination. Thank you. Stay healthy.
Thank you, Dr. Sajesh, for the detailed presentation. I think you have covered almost everything, you and Indrani madam. And can we go to the questions in the chat box, Sajesh? Dr. Sajesh?
Yes. Yes.
Dr. Sajesh, there is a question from Dr. Kamesha Ramu. What's your experience in survival rates after endotracheal intubation and mechanical ventilation?
Not clear. Rajesh, what was the question?
What is your experience in survival rates after endotracheal intubation and mechanical ventilation? From Kamesha Rao.
My first wave, my experience is, I have personally intubated around 50 patients, and only 4 of them are survived actually. Out of 40 actually, 40 intubated 40, only 4 survived. All other died. But in present day, actually, the situation has a little better. I don't know, because of the better understanding of the COVID, maybe we are getting around, still we have around 80% of mortality in intubated patients.
That's the same opinion, Dr. Sajesh, from Indrani madam also. She has also mentioned that their survival rates after intubation is not good.
But the problem is that the main problem what we are facing, or a very distressing thing, is that in the second wave, we get plenty of youngsters. That a 20-year-old, we lost a 22-year-old person, lost a person, 24, 30, 35 youngsters we are getting a lot of patients we are lost actually. But when the first wave, when we were there in Mumbai, actually the situation is that I have around 300 beds statistics, and my ICU are around 100 patients. I looked after, and in 2 weeks, in 2 months time. But entire the 300 patients of that period in our hospital, and none of them was less than 30-year-old age actually. Those who are died or are critically ill. All of them are aged and comorbid patients. But in a second wave, the issue is that even 20-year in our ICU last week, we lost around 22-year-old person with very stiff lung. That is the situation what we are facing. That's only overall mortality is not high with the second wave, but the point is that a lot of youngsters are involved, badly involved, and most also.
And that's really scaring, Dr. Sajesh. A lot of youngsters with without much comorbidities.
Yes, exactly.
Yeah. So there is a question regarding.
I cannot pick out anything.
There's a role of incentive spirometry. I think it may have a role in the rehabilitation phase.
Yes, definitely. That's one of the key thing actually. That's what I said. Actually, most of them are lung involvement, especially is more than 15 of CT score and all. Most of them will get thrombotic and fibrotic lung in the majority of the area. And to expand it, actually, we need a graded spirometry and all. That's only rehabilitation, physiotherapy and spirometry and all is very key, actually. That's the key thing, rather than this antifibrotic medicines. We don't have that much promising. Of course, some medicines are trying, but that it's a promising thing. Not that much promising medicines came up, but the thing is that the fibrotic lung, what our colleagues actually, friends on respiratory medical pulmonology fronts are saying that, but the very promising thing is that around 6 months period, by the time of 6 months period, majority of them, the fibrotic lung will recover actually. That's a good news actually, with supportive care and early treatment and support.
Maybe the incentive. Yes.
Post-COVID.
Does incentive spirometry has got a role in the early phase? Like once the disease is diagnosed in the early phase to prevent the lung involvement?
The point is that I can't say. Actually, we are not using it regularly, because the more we get a patient, the very sick patients actually. It's very difficult for them to educate or force them to use an incentive spirometry. Maybe good one, but practically what we are feeling is that it's very difficult for them because they are fighting, they are anxious, they are very much apprehensive and all of things. They are fighting for the oxygen, and so that time is a bit, removing the oxygen and do an incentive spirometry in the initial phase. Of course, in the late phase onset, in the recovery, definitely we are using it. But in the early phases, especially patient coming with a desaturated, coming to ICU with NIV, putting on NIV and all things, is very, very reluctant. They are very reluctant actually.
Okay. So there's another question. Does the scavenging system need filters or HEPA? What's the difference between scavenging for anesthesia machine and ICU ventilators?
And actually, this is ideal thing is through the HEPA. Actually, the exhaust should be go to the HEPA and filter through the HEPA and keep it out actually, because the exhaust can contaminate other areas actually, exhaust air. That's ideal thing.
Dr. Sajeesh,
anesthesia machine, actually we can have an active one, but the point is that most of them don't have the active scavenging system. Most of the area we don't have an active scavenging system. Then we can have a 1% hypochlorite dip. Yes, Rajesh, please.
Yeah, Dr. Sajeesh, in your experience, how significant is lung involvement in post-vaccinated patients when they get to COVID? It's generally believed that they have a better recovery and lung involvement is less. Is it true?
Definitely. None of our patients with 2 vaccine after 14 days, none of our patient has got a very bad lung, or none of them has died actually. Okay. Even that's my limited experience on the second wave, and that is very sure actually. The vaccination, of course we know that how the vaccination works actually. It's only it's sensitizing effect. So we give a clinical dose of things and sensitize our immune system, and activate our memory B and memory T cells. So initial sensitization, rather than our storm of events, of inflammatory events or cytokine storm or high dysregulated immune response, we get a controlled way of stimulation. Of course, that we get a few days, first few days we get some fever, body ache, or because of the immune response. We don't get a classical dysregulated immune response with vaccination. I don't say. So that's why the patient won't get that much, won't deteriorate that much as in a normal infection.
Okay. Dr. Sajeesh, what we observed is that most of the healthcare professionals, they take all precautions when they are in the ICU or in the OT, but most of them get infected when they go outside. And when they
more than that, more than that, I forget to mention because I just skipping him off. The thing is that even in our ICU, in our OT and our ICU, even in the first wave, what we felt was then the common thing is we put a full coverall on everything and proper precautions, everything we can take. But the point is that we remove even our mask at the time of common dining actually. Yeah. This is the one area we get more maximum infection, especially in hospitals and offices actually. Okay. Yeah, we may be relaxing at that coffee break. We are relaxing with our friends. We are chatting, cracking jokes and all the things. This is the area we are removing the mask and everything. So N95, this is the only area we will remove the N95 mask. And we had a few incidents. Even in the first wave, we had a bout of infectivity among the staff members from the common dining area.
Yeah, that's very true. Dr. Sajeesh, what's your projection about the third wave? When is expected to happen, and what will be the age group of people which are likely to be affected?
Yeah, the thing is that Especially what we can see any pandemic, say even from the flu itself, we know that flu almost 5 crores took away the almost 5 crores people in the world, and the classical flu. But the point is that the second wave is more dangerous or devastating than the first wave. And the third wave, of course, have a more devastating effect. But here the advantage or the promising, the good position is that we have a vaccine here. So if we have a good vaccination coverage of more than 70% of the community, you can expect a good outcome in the third wave. Definitely the third wave will come. But what happened in the second wave is that, because the three things are there. One is the increased mobility of especially the youngsters, and increased mobility. Second is that COVID protocols, we are not strictly following the COVID protocols. And third thing is the variant. Of course, 50% more effective variant has came up actually. So that these three things, especially the youngsters, they are moving out. And most of them are not vaccinated, because we are not targeting from the 18 to 45 at the beginning. So the thing is that that age group has succumbed badly in the second wave. That is the thing. That's why the most of the young productive age group are not vaccinated. So, and they are affected most and badly affected in the second wave. And that's why everyone is predicting that in the third wave, youngsters, especially the adolescents and the kids, actually young children, and can affect, because they are not exposed to vaccination. So this is the one age group is not vaccinated. So we can expect in more youngsters to be affected, especially young children. And already that panic situation has created some panic especially in some part of India. In our country is that even advanced booking of the pediatric ICU has started even for the third wave. And the unfortunate thing is that if that kind of a panic in the especially pediatric age group will be affected, or they are getting affected, especially since they are the children are affected, we are more emotionally bound. So that can produce a very panic situation in our country in third wave. So my position is that vaccinate maximum possible within a 6 weeks of time. For 4 months or 5 months or 6 months, within 4 or 5 months, we can expect that.
So there's another question from Dr. Kamesh Rao. Are you using standard dose steroid or high dose in the ICU?
ICU key is a 6 milligram dexamethasone. That's our main key dose actually. Even equivalent dose of methylprednisolone we are using. Only we use actually for the cytokine storm situation, hyperinflammatory situation, we use 200 milligram or higher dose. Or in a patient condition worsening, that is a pulse, as a pulse therapy we use high dose. Routinely we are not using high dose.
Okay, Dr. Sajesh. Another question is role of baricitinib in COVID.
Baricitinib, actually, it's not included in our protocol. That's why I'm not mentioning it. I will still in the most of the part it's available there, and I think it's more. It will come in our protocol sooner because of the this thing, the CAM effect or COVID-associated mucormycosis. There is a trend of reducing the usage of steroid. I'm not quoting it as a misuse, but excessive usage of steroids. There will be a tendency. Actually, some guideline discussions are going on with the baricitinib. Actually, if that is one of the advantage of baricitinib is mainly useful. Those can't afford steroids.
So there was no mucormycosis in the first wave, no?
Yes. I didn't see the mucormycosis in the first wave. Second, I have seen it.
Yeah, that's surprising. No, that there's any reason for the mucormycosis in the second wave?
No, the mucor, the point is that mucor is not a new thing in our country. Actually, it's there, but especially in uncontrolled diabetes immunocompromised patients. Maybe our steroid may be attributing to that, but I'm not, as a common rule, I am not quoting that word, yes, because that may actually limit the use of steroid, and the steroid is the only one drug which is found useful in the overall COVID management. So you should not discourage the steroid usage because of the fear of the mucormycosis scam, COVID-associated mucormycosis. You know, that should be the message you should go. And the point is that it's in a pretty. I have seen a few patients with very uncontrolled diabetes, immunocompromised, and these kind of situations. When steroid may be aggravating the situations, but the thing is that you should control diabetes, and that's it.
Any role for methylene blue?
I don't think I have no experience with methylene.
Ivermectin, it is disproved now.
Yeah, ivermectin is.
Any protective role for other mRNA vaccines like influenza vaccines and all?
Other vaccines means other than the
other than the COVID vaccine, other mRNA vaccines. Now, you know, we have influenza vaccines. So does it have any cross protection?
Actually, we don't have any. The major studies has not been established.
Yeah.
Not come up with on that aspect. Some are saying that actually these discussions were started when vaccines was not ready. Actually,
Yeah.
but now the point is that we have around 10 vaccines there in our armamentarium. We have 10 enough vaccines are here. Only the enough doses we are not getting it, that's an issue, but still we have around 10 vaccines in all over the world is available.
So
you have a specific vaccine, then why should you try for the alternate?
That was an alternative suggested before the era of vaccines, like influenza vaccines and MR vaccines and all, because the theory
even BCG was discussing on that. Everything was
so hope vaccination is the only way forward.
Definitely, vaccination is the key. Actually, the only thing, vaccination.
So another question is regarding the temperature maintenance in the vaccination center. It's very. You can see, Sajesh.
No. What's that?
Do you agree that the temperature is not maintained for vaccine kept in the vaccination center? Does it affect efficacy?
Definitely. Cold chain is the key in any vaccination. Only vaccine can be very freely we can use is a Sputnik vaccine. That's a crystalline powder actually. That's the only thing. All of the vaccines need at least a refrigerated temperature, 2 to 8.
What about the Bharat Biotech vaccine? That also needs
that has to be not to be freezed, but refrigerated temperature.
Difficulty is to maintain the Moderna vaccine and all. Storing the Moderna vaccine. Moderna vaccine, no?
Moderna?
So that needs minus 20 degrees centigrade.
Actually, the mRNA vaccines, they need a very low temperature. That's the only problem with mRNA. Otherwise, the mRNA vaccines, that's why the mRNA vaccines are not popular, because a country like our is to the even to the injection site, actually, the vaccination center is very difficult to maintain the cold chain, actually. That's one of the problem with the mRNA vaccine. In a very hugely very big populated country like us, that's a problem. Otherwise, that's the best vaccine we can have. Around 90-95% we can have protection.
Thank you, Dr. Sajesh. If there is no more questions, we can wind up the session. Can we wind up the session, Doctor? Over to Dr. Binil.
Thank you,
Dr. Nazar.
Thank you, sir, for the excellent presentation. Before winding up, I would like to announce our next week's program. So next week, Saturday, there will be 2 sessions. The first topic will be sepsis and septic shock guidelines-based management by Dr. Suresh G. Nair, senior consultant, Department of Anesthesiology, Aster Medcity, Cochin. And the second topic will be airway management in the critically ill, what is new, by Dr. Sheila Nainan Mitra, Professor, Department of Anesthesia and Critical Care from Tata Memorial Hospital, Mumbai. So I request our PG students and consultants to attend next week's session. And I thank today's speakers, especially Indrani Madam, for that excellent presentation. Madam is the professor and HOD of KEM Hospital, Mumbai. Thank you, Madam, for enlightening us today. I also I extend my sincere thanks to today's panelists, Dr. Sunil Pandya from Hyderabad,